not wrong. And he is an epitome in his work on, as we know, the deformity correction of knee during joint replacement surgery and dealing with instabilities in his own inimical way. So welcome on board, and thank you for joining us, John. And without much ado, as the time constraints are already 8 minutes down the line, I would just ask you to start your talk and enlighten us about the journey which you are going to show us in last so many years of your experience in instabilities of knee and their deformity corrections while doing joint replacement surgery. And you have about 12 to 15 minutes, I think, and you've already given your talk to Dr. Rajiv Sharma. So Dr. Sharma would be sharing the screen.
No, Dr. Briard will share, I think.
I thought that you had the talk, he was just telling me.
Yeah, he would like to share, he'd like to control himself, yeah.
Sure. So I would let the stage on and you can start sharing the screen now. So,
Janvi, are you okay to share the screen?
Yeah, if it's a bit changed.
Sir, please share your screen.
But well, I want to share, and I have nothing.
Dr. Rajiv, do you have John's talk?
Yeah, I'll do that.
So please, you share the screen so that he can talk.
Yeah, don't worry.
And he can ask you to change the slides if needed. John, are you good with it?
Yeah.
Yeah, thank you. So he would be talking on constraints in TKR and overview for such in an unstable total knee.
Okay, you can hear me?
Yes, we can.
Yeah, but I can't change.
Yeah, you please tell me.
We change. Okay, so revision of total knee, it's a big subject. So aseptic loosening is the most frequent cause, and after infection, but instability is a third cause, and instability is the leading cause of revision for less than 2 years after primary knee. Change? Okay. In unstable knee, it's most commonly diagnosed by the patient. He has no trust in the knee since surgery. And here he complains of giving way, buckling. Well, so instability is obvious, but there are less obvious instabilities and which give trouble when they give out of a chair on and in the stairs. And very frequently they have recurrent dislocation. Go. Okay, so physical examination must be systematic, and the gait, we must look around the gait, and we must look at the limb alignment. We must examine the knee, range of motion, but also varus valgus stability. And we must look for localized pain, but quadriceps strength also. Next. X-ray, we ask for standard X-ray, but we need a long leg standing X-ray because they give the alignment, and especially they look for extra-articular deformity. They look for sizing, rotation, and bone cuts, etc. Later, if necessary, we will do stress X-rays and CT if there is a fracture before or if there is a patellar dislocation. Next. So it's very important now to know the previous deformity and the detail of the surgery. Intraoperative complication, bony cuts, ligament release, and also to know the comorbidities. It's play a role in the indication of the treatment. Next. So indication. So now we look at is surgery indicated. So preoperative planning is very important. It's like a primary. It's even more important than a primary. So we look at the proper, how to get proper alignment and what is the rotation of the component. We will look how we will correct the bone deficiency or how to equalize the flexion and extension gap, restoration of the native joint line, soft tissue balancing, and at the end, level of the constraint. Next. Okay, then surgery. At surgery, it's the best time to know about the implant. So we check the alignment because it's open. We check the rotation of the component. We assess the soft tissue in extension in 30, in 0 degrees, 30, 90 degrees in the concavity and in the convexity. So we have full knowledge. And then we remove the implants. Next. So then we correct, so the implants are removed, we correct the bone, and well, we look at the bone deficiency, and we look at equalization of the extension and flexion gap with the right joint line level. We know that soft tissue balancing is very important in flexion and in extension, and femoral implants are important because their size, augment, and rotation with reference to the transepicondylar line. At the end, we will look at patellofemoral tracking, and we choose the right level of constraint. Next. Well, classification, there are many types of classification of instabilities. We have extension, flexion, combined instabilities. We have mid-flexion instabilities. We have patellofemoral instabilities, late instabilities with loosening, wear, and ligament abnormalities. And we have extra-articular deformity. It's very special. Unstable total knee. I think it's important to know the deformity we had to start. And then we will know, we want to know if the ligaments were good, if the ligaments were good, but not the knee well aligned. And then if you have a incompetent collateral ligaments. Next. Well, that's a mistake of me, or my case. Well, it's 30 years ago. I did mistakes, and I think the solution in this polio patient was to use a hinged knee. Cruciate retaining total knee. Well, we know that if they are too tight, that's lead to progressive subluxation. And we can treat them with flattens, we can treat them with curve insert, but most of the time we will use PS knees. Okay, so now we start with well-aligned knee with good collateral ligament. So that means that if it's unstable, we made an error in bone cuts of polyethylene wear. So if it's in the bone cuts, for the tibia, it affects both flexion and extension. For the femur, it affects, if it's distal, it affects the extension gap. And but it can be mistakes in the apicuts, and that leads to instability or sometimes even to dislocation. Next. Well, this knee, was totally unstable, but was very easy to correct because we had good collateral ligament to start. Next. That's patellofemoral instabilities. That's due to error in the apicuts. And we must have a CT scan before, because we know that a revision for patella is not a quick, fast surgery, because we will have to correct the internal rotation of the femur or of the tibia. Next. So now if we speak of malaligned knee with a fixed flexion deformity, that means we had the need to release a good quality collateral ligament. Next. Okay, if you have contraction of the posterior capsule, it's sometimes difficult to recognize it in revision. So they find that the knee was too tight in extension. Well, we resect more bone distally, and we end up with Mid Flexion Instabilities. Go ahead, next. Yeah, because the stability in extension is given by the posterior capsule, but you see the collateral ligament is loose. So as soon as you bend, you have Mid Flexion Instability. Next. Okay, fixed varus. Next. Okay, insufficient release with residual lateral laxity. Well, we know that bone cuts are not enough, and we can see here. Next. So in this case, okay, in this case, well, the release medially was not enough. We had lateral laxity even at the beginning, and then it became bigger and bigger, and lateral laxity, and we had to revise it with TC3. Next. Not a transected MCL, and when it's chronic, it may need a hinge. Next, but PS are not enough to control this, so it's better to repair them when we do the MCL injury. Next, and it works very well in emergency. Femur varum, that extra-articular deformity, that transepicondylar line is oblique. Okay, well, you can say, okay, I do a MCL release and I will get the correction. It will be well aligned. Next. But in order to be inflection, if you take the independent cut, you will have medial laxity. If you do the flexion gap balance with the extension gap, you will have internal rotation, and you will have subluxation of the patella. So next, if you have a femur varum, you have to do either a metaphysial femoral osteotomy, or if you want, you can do a sliding medial condyle osteotomy here, or you have to accept the residual varus deformity. Next. So when we see an unstable knee, the first question we ask, was it a genu-valgum? Next. Okay, genu-valgum, if you have a poor technique of lateral release, and if you release completely the LCL and popliteo, well, you end up with unstable knee. Next. Okay, so this knee, well, obviously everything was cut, and I think you need a hinge. Next. Okay, this knee was well aligned, but they use independent cuts, and so they take the reference to the posterior condyle, and they end up with a lateral flexity inflection, and it was dislocated after surgery. Next. And so in this case, you can increase the rotation of the femoral implant, but most of the time you will end up with a TC3 or hinge. Next. Insufficient lateral release with too much excision, too large excision of the medial condyle. That gives medial laxity in extension. So the next. So you see here, it's we release here, but not enough, and we cut too much of the medial condyle, and this patient end up with a medial laxity. Next. So, genu-valgum type 3, you have the high tibial osteotomy, and that gives a tibia valgum. And you see, we will have to remove a lot of bone medially. Next. And you see the guy did the good bone cuts, but he had laxity here due to the removal of too much bone medially. And even with revision, it was not good in 97. Next. So we decide to correct the laxity here with a bone augment, and then we had to correct the tibia valgum, and that was perfectly okay. Next. So now we will, that's the most difficult knee, because this knee have poor quality collateral ligament. So genu-valgum type 2 with elongated MCL. And in this case, you have no choice than using a hinge. Next. You see, in this case, we use a hinge, a Guépard. That's a long time ago. But sometimes we can use a TC3. Next. Or we can use, if the medial collateral ligament is not bad, well, then you can use a sliding osteotomy medially. Well, now you have the late complication. You can have a post which are fractured, or you can have a bone loosening, or you can have elongated soft tissue. So I think when you plan a revision for instability, you must know precisely the previous situation, the cause of instability, and then go through the bone cut, through the bone stock, the bone cuts, value of the ligament, the rotation of the position of the implant, the value of the extensor mechanicism, and be prepared. Thank you. Oh,
thank you, John. It's a wonderful presentation. And for the unstable knees, we all know that you are the best. So the forum is open for questions. Vikas, can we have 2 questions?
No, after.
Okay.
Can you see my screen?
Yes.
Yes.
Right. So my video is edited because exactly to 5.5 minutes. So time won't be a problem. So
deformities from 10 to 20 degrees usually need bigger releases, reduction osteotomy, downsizing the tibia.
So this patient, you can see we are discussing the left side, and this patient has about 25 degrees severe varus with lateral laxity. So we can have severe varus, but we are talking of cases with lateral laxity. So this is a very severe varus, and if you see 1/3 of the tibial plateau under the medial femoral condyle with 1/3 of the tibial condyle subluxing, this is very severe case with a lot of lateral laxity. So this is severe varus, 20-25 degrees with bowing of the tibia as well. You can see varus of the tibia also here. So varus of the knee, varus extra-articular at the tibia as well, with a lot of lateral laxity. And our concern here is the lateral laxity. That's what we're talking about. So this patient has about 26.5 degree varus deformity. You can see that, and you can see on the ligament balance screen that the difference in extension is huge. After removal of the initial osteophytes and tibial downsizing, the varus still is 12 degrees. So you can see the difference in ligament laxity is huge. It's 15 degrees on the 15 millimeters on the lateral side, 0 on the medial side. So that's the amount of lateral laxity. And the way to handle is, of course, tibial downsizing and reduction osteotomy. So you downsize the tibia. You can see we're downsizing the tibia from a 3 to a 2. And that's one way of releasing the tension on the medial side. So you can see that we are downsizing. We'll take a saw and take all the extra flare of the tibia off and correct the deformity. And in case the deformity is not corrected, then we'll discuss as to how to handle further lateral laxity. So this patient, especially we are discussing severe lateral thrust. You can see after downsizing, there is still a lot of lateral ligament instability. So extension, asymmetric lateral opening. This is because the patient has been walking on lateral thrust. So this is 11.5 degree varus, still with a lot of lateral opening after tibial downsizing, after all the osteophyte removal, after reduction osteotomy. You are still seeing that the gap in extension is huge. In flexion, it is decreasing, it's equalizing, but in extension, this gap is huge. And this is the time that we decide to do a medial epicondylar osteotomy. So remove about 1 centimeter of bone from the medial epicondyle with a sharp 20 millimeters osteotome, and remove the medial epicondyle with the soft tissue intact, with the periosteal sleeve intact, till you correct the lateral extension instability or lateral laxity. That is the topic that Vikas gave me. So lateral laxity in extension, in spite of correction by reduction osteotomy, by downsizing. Now you can see that after the osteotomy, the tibial and the femoral condyles are touching. So lateral laxity is now in control, decreasing after the medial epicondylar osteotomy. So medial epicondylar osteotomy is indicated when you have very severe lateral collateral residual laxity, even after all the medial soft tissue releases and tibial downsizing and reduction osteotomy. At that time, you do the medial epicondylar osteotomy and allow it to come down and posterior. So the osteotomy comes down and posterior, and then you fix it with a provisional K wire. Fix it where it comes naturally with a provisional K wire. And then you can see now that the lateral laxity is well within control, well within 2 millimeters, 3 millimeters, and medially also the gap is nicely open up. And then you fix it with one screw over a washer or anchor suture. These days you can do with the anchor suture as well. We prefer a screw. And then the knee is nicely balanced. You can see 5 degree flexion. From 11.5, 12 degree varus, we have come to about 1.5 degree varus. And now this is a nice railroad balance. You can see 6, 3.5, 4.5, 3.5. Gap is 2 millimeter difference. Earlier it was almost 15 millimeters of difference. So 2-3 millimeters difference. And this is nice fixation with this screw. And this is the final ligament balance with the navigation control. So these cases are best done under some kind of technology assisted tool so that you can control the osteotomy very well. You can see the long leg alignment is perfect. We're well within a degree or two of varus alignment. Osteotomy is well fixed with a screw, and overall alignment looks pretty good. The balance is nice. So medial epicondylar osteotomy is a great tool to
25 degrees if it's uncorrectable, some 25 plus.
So medial epicondylar osteotomy is a great tool, a great adjunct to correct the lateral laxity, residual lateral laxity in extension, especially that persists after all the medial release, downsizing, and reduction osteotomy, and best done under navigation or robotic assistance. Thank you very much.
Thank you, Anup. That was wonderful, absolutely on the point and wonderfully explained. So we had causes and corrections of valgus thrust very, very clearly elucidated. Now we would have Sanjeev, our friend Sanjeev Jain from Mumbai, to talk about exactly the opposite condition.
Vikas, are we going to have the opportunity to discuss a point here and there,
Yes,
or is it just a series of didactic lectures that you have planned?
There would be 6 of these, and then we have 15 minutes of time when we can note down our points and discuss all the lectures.
Okay.
That's what the agenda is.
Okay.
So can we have Sanjeev talking on exactly the opposite situation, the hypervalgus knees, and addressing the medial insufficiencies? Sanjeev.
Hey, good evening, everybody. So
Time
I'm
starts.
talking on the hypervalgus knees addressing medial insufficiency. Can you see this right? When it's shared.
Yes, please start.
Okay. It's always a challenge to deal with in valgus knees. There are many technical aspects, and one is the surgical exposures, femoral cuts, tibial cuts, balancing of medial collateral, lateral flexion, extension, gap balancing, and of course, having an excellent implant with regards to the constraint. Now, valgus knees, you can think about doing on the lateral side, correction, alignment in both the planes by assessing the deformity and different methods which you'd like to use on a bony side. Same thing, you can talk about doing a lateral side, the way you have learned and what the procedure you're doing it to release on the lateral side. But the main problem remains here is the attenuation of medial collateral ligament, MCL. And when the MCL is incompetent and the deformity is severe, I think that's a very difficult and challenging situation, which is really the nightmares for the surgeon sometimes. Now, if you look at the literature and if you see that the whole valgus knee correction, the soft tissue balancing in a primary knee, in a valgus knee, in a severe form of the medial insufficiency is always a great challenge. We can use the tool either the conventional way, or you can use the tool like computer assisted or robotic. We use a classification. There are many classifications are available, and which also address the medial side attenuation or of attenuation at the different degree. Initially, we definitely used to use a classification described by Dr. Ranawat, and which has been used thoroughly and which is very practical. There are newer classifications which is available, which says whether your valgus deformity is correctable or not correctable, whether fixed. You can use the combination of all those and plan the surgeries. Full alignment X-rays are always good to have it, and especially to rule out if there's an also associated extra-articular deformity. The 3 grades of valgus deformities can be treated, but we are talking about the medial insufficiency or medial incompetence today in this particular lecture, which has been given to me by Vikas. Now, medial reconstruction, after doing all the procedures, cuts, balancing, but having a medial reconstruction done, handling the MCL described by the Krakow, where you can, lift up a medial collateral and fix up with screws or different kinds of washers. But in osteoporotic bone, it remains a challenge or a problem, and that can lead to a failed procedure or recurrent valgus deformities. And this is the kind of implant or screws has been recently described, which can give a better fixation, and you can address the medial insufficiency using a normal implant even as well. The medial epicondylar osteotomy, which is a sliding up osteotomy, has been described, and which also provides an excellent correction to deal with this form of insufficiency. And this can be also be used as a really, really great tool in terms of severe medial insufficiency is concerned. You can address this problem better with different kinds of constrained implant available, either the CCK type or maybe if it's a huge global instability, then you can possibly use, especially in a very bad rheumatoid, when you have a complete insufficiency with an hinge implant. So this is one of the example using a CCK implant, and you can also use definitely a hinge implant if needed. You have a varieties of literature available to show the excellent results of CCK implant or a constrained implant, and all outcomes has been compared between the rotating hinge or between the constrained implant, and have an excellent results if all the things are performed well. So you can, in a medial insufficiency, you can deal with the medial collateral. You can use either a washer technique, whether you can go up and tighten up the medial collateral along with using an appropriate implant, or you can do a medial sliding up osteotomy. And if everything fails, then you have other forms of implants available to deal with this kind of situation. Thank you.
Thank you, Sanjeev. That was short and quick. There would be some burning questions, I'm sure, regarding the cuts and etc. in the discussion coming up. I would now invite our next speaker for a very difficult situation, the primary recurveitum, and addressing the posterior laxities, Dr. Hemant Wakankar, who is well known to all of us, champion in Pune in joint replacement surgery. And welcome, Hemant. Please start your talk now.
Thank you, Vikash. You can see my screen?
Yes, we can. Thank
Lovely.
you.
My brief is to talk on TKR in recurveitum, and it's basically about addressing the posterior laxity. Now, let's consider the pathological anatomy in recurveitum. And it's the posterior capsule is completely stretched out, as you can see, and the collaterals are stretched out as well. And along with that, you will have varying amounts of bone loss from the anterior tibia and the anterior femur as well. So let's consider recurveitum in rheumatoid arthritis. It's usually the soft tissue laxity along with the bone loss. So it's a combination of both soft tissues and bone loss as well. But in primary osteoarthritis, when you have recurveitum, it's primary bone loss and soft tissues usually are not so stretched out. Obviously, one needs to rule out neurological disorder, especially progressive neurological disorders. And any case of hyperextension, one really needs to be aware of the progressive neurological disorders, which may present very subtly. And these could be cervical myelopathy, this could be a case of Parkinsonism, or any other upper motor neuron lesions that may not be as obvious or subtle. So most patients of these hyperextension deformities need to be referred to a neurologist to find out if there is any obvious cause underlying. Now, TKR in recurveitum, we obviously need to alter our surgical plan. And what you really expect is laxity and extension if you do your routine cuts. PCL is usually stretched out, so minimal you will need to use is a posterior stabilized prosthesis. And you also need to have backup options available, especially the hinge with an extension stop. So it is the mismatch between the extension gap and the flexion gap if you do your routine cuts. So you need to alter your surgical plan. One needs to minimize the distal femoral cuts and try and balance that with the flexion gap as well. Obviously, one is not going to do any soft tissue releases posteriorly. Sometimes even the big osteophytes posteriorly may need to be left alone if they are providing some stability posteriorly. Some examples here. This patient presented with this degree of 20-25 degrees of hyperextension, and this essentially was osteoarthritis with significant bone loss, and that is under anesthesia. As you can see, the most of the bone loss was essentially from the anterior tibia and the femur. And the simple alteration of distal femur by minimum taking a -2 distal femur cut sufficed here and got the deformity correction. Just to show you the video of patient walking before surgery and that is following after surgery, that alone suffices here that it gives a full correction of the deformity. Here is a patient of rheumatoid arthritis with extensive bone loss. So it's a combination of both soft tissues and bone loss as well. And this is the stress views, both varus and valgus stress of the same patient. And that is the amount of hyperextension you have. Now here again, you need to minimize both the tibial and femoral cuts and try and get the balance. This is the kind of typical inflammatory arthritis that you get. And that is the post-operative X-ray of the same patient. Now, here is a patient who presented with almost 45 degrees of hyperextension deformity. And she, although was cleared by the neurologist, she had subtle cervical myelopathy and she was only 45. And, the obvious question is whether one should be using a hinge at this age. And, one should try and not use a hinge at this age because you'll be burning out your bridges if you needed to revise that knee later on. So, this is the kind of hyperextension that is there just as I started my surgery. Here is after by putting my distal femoral cutting jig. And I have in fact taken a -6 distal femoral cut. So put my pins in a +4 position and shifted it to -2. So that is -6 distal femoral cut. And there are very little bone taken off from especially the lateral side. As you can see, it's barely a cartilage level cut on the lateral side. And at the end of the surgery, I got the knee at about 5 degrees of flexion deformity. And in fact, I left her in 5 degrees of flexion deformity using a standard posterior stabilized knee. And unfortunately, in fact, I lost this patient to follow up, but I understand about 8 or 9 years down the line, she's started going back into hyperextension. I haven't seen the patient over the last few years, but I understand this patient has started going back into hyperextension. Now, this patient presented with this hyperextension deformity, obviously had pes cavus, had cafe au lait spots. So this obvious diagnosis was neurofibromatosis. Now, in such a patient as well, one has to warn the patient that the deformity can recur. And this deformity was not too huge, so again got away with minimizing the cut, and that is the kind of distal correction that we got. This patient presented to me 7 years later, and as you can see, this patient has started developing this subtle deformity. Although there was no hyperextension, obviously, but he started developing the stretch out collaterals, and he started developing that recurrence of the deformity. So that is a big problem in this patient. That is an X-ray of with posterior stress. As you can see, the slide, some posterior major subluxation there. In severe hyperextension, one really needs to use a rotating hinge with an extension of bumper stop. The trouble is that if you use these hinges in a younger patient, you can certainly have a risk of anterior wear, wear of that bumper stop as well, and some degree of wear of the poly bushing as well, and early loosening. That is a big problem using this hinge in younger patients. So to summarize, I think one has to be aware of progressive neurological etiologies. One has to reduce the distal femoral cut to tighten the extension space, leave the knee in about 5 degrees of flexion. One may try and use a brace to keep the knee in slight flexion. Thank you very much.
Thank you. And that's a wonderful and very quick resolution to a very difficult situation, which we all face sometime or other. And now we have our very experienced ex-president, Dr. Bharat Modi, with us, who will actually be talking about all around loose knee, globally loose knee. God knows how he gets one, but I did face one situation once, and he's going to talk about it. Bharat Bhai, it's up to you now.
Thank you. Just a moment, if I could just.
Yes.
All right, here we go.
Yeah.
Thank you. So, usually when you talk about a globally loose knee, or even the hyper extension or recurveitum knee, as just Hemant has just pointed out, there is almost surely a neurological pathologies, a neuropathic pathology behind that sort of a deformity. And this was recognized as early as 1868 by Jean-Martin Charcot and the other names that you see there. So it's not something new on the palette of joint replacement surgery as a whole. But yes, it is one of, unfortunately, it's rare, and therefore it makes it even more important to understand what might be the most dependable way. And that is what I'm going to discuss also along with a couple of my colleagues who have given such incredibly educational lectures just now. Neuropathic arthropathy, also known as Charcot joint, refers to progressive degeneration of a weight-bearing joint, a process marked by bony destruction, bone resorption, and eventual deformity due to loss of sensation. That's very important, that loss of sensation part. The common underlying etiology could be any one of those things that you see here. Hemant also mentioned a couple of these neurological problems that can be the underlying cause. But suffice it for the moment to say that some or the other neurological problem is part of this pathology. Eichenholz classified the disease into 3 stages: the stage of development, stage of coalescence, and stage of reconstruction. But recently, Parvezi argued in their hallmark paper that there were no distinct stages of arthropathy. They observed that fragmentation, destruction, and coalescence coexisted in the same knee. And I would tend to agree with Parvezi based on my own experience over the years of having when I've encountered these sort of joints. But in any case, it makes it easier for a beginner to understand what is meant by the stage of development, coalescence, and reconstruction. The 2 widely accepted theories are the Neurotraumatic Theory, which proposes that neuropathy and repeated trauma, because of lack of sensation, repeated trauma produces this joint destruction. And there is a hallmark when you see a grossly destroyed joint, with the patient not actually indicating as much pain as you would expect, the patient has come to you more for instability rather than pain. The red light here should start flashing that this looks to be not a standard osteoarthritic pathological process, but more importantly, something on the lines of what we are discussing just now. And then there is this neurovascular theory, which suggests that it is the micro peripheral blood flow disturbance which results in osteolysis and demineralization. Both of these theories are more to do with theory rather than the practice of treatment of these particular problems, and we'll come to that in a moment. Typically, you will see a progressively increasing swelling of the joint with huge amount of synovial fluid collection. There could be some erythema and increased local temperature. Tenderness pain can or cannot be there. Certainly, it is less in proportion as compared to what you will see clinically as the destruction of that joint. And of course, instability is the hallmark. There will be gross deformity, bone loss, ligament laxity or incompetence. And the question will be how to handle this, which type of prosthesis should be used, what type of surgical technique should be deployed when you start with this particular problem. Prosthetic, just a moment, please. Oops, kya kiya maine? Okay, prosthetic. What are the typical complications that you might end up if you don't recognize this problem or understand or appreciate it properly? You could end up with a periprosthetic fracture, something like MCL avulsion, patellar tendon rupture, tibial tubercle avulsion, and residual instability. So I'll skip this slide. It's basically just a compilation of the significant papers that have been published. You will find in the literature search that there are not as many papers on this as you would otherwise expect, considering that it's a significant problem. And the reason for that is that it's not, thankfully, a very common problem. So here, I will try to make my point with two case reports or case examples, rather, from my collection of these particular rogues gallery. So here was a patient of 68 years old, 8 to 10 year history of gradually increasing deformity at the knee, very minimal pain, known case of diabetes. So basically, she was probably a victim of diabetic neuropathy, resulting in the Charcot joint type of a problem. And you can see the just plain sight here shows you gross global laxity. X-ray showed gross bony destruction as well as new bone formation, which is again a hallmark of this. And you can see how grossly, lax and globally lax the knees were, along with this hypertrophic bone formation going around the entire joint capsule. So as I opened this up, you can see that the patella was also like a cauliflower hypertrophy. And what was interesting is even in this grossly deformed knee, there was still some semblance of a posterior cruciate ligament bundle. This leads to some, but anyway, that's a point to be made in some other lecture as well. But the point made here is before the bone cuts, I could put in this particular size spacer. This is before I have taken any bone cut. It is basically to convey the message that how grossly lax the entire capsular structure becomes, not just the collaterals, it's the entire capsular structure. So how do you approach this? Hemant just, the same was with the extension. So now I started cutting, and as Hemant said earlier in his case example, if you have two options, actually the answer to something like this is very simple. In the modern day, unless you want to be unless you are an Arjun and you want to try something really fancy, you don't need anything other than a hinge joint as your answer. You will not be faulted if you take hinge joint straight away as your answer in this type of knees. In the days when I tackled this particular knee, I don't think I took the option that I'm just about to show because I thought I was an Arjun then, or even now, but because I didn't have a hinge joint accessible to me in those days in the city of Vadodara. So what I did was, and you can see here, what Hemant just described, a cartilage cut. So hardly anything. I took almost nothing away from the tibia except just to get a plain surface. And that allowed me just to sit that implant thickness, which was available in form of the thickness of the insert that I had with me with a TC3 system. Then I went to the femur, and once again, as you can see here, hardly anything. The lateral condyle of the femur is not touched at all. And the medial condyle is also probably around 2 or 3 millimeters. And that gave me a very, very good, filling up of the extension gap. And then went ahead and did the same thing. I mean, for some reason, I don't have the sequential slides to show that I did more or less the same thing for the flexion gap as well, in as far as AP cutting of the femur was concerned. And then I used TC3, and therefore you see those medullary canal opened up quite well because I put in those extender rods. Used a TC3 system with a thicker insert than normally what I would. I don't know exactly remember what, but I think these are 17.5 or maybe a 15 insert. This was the bony debris which I had taken out, including the thin slices of the tibia and the femur. This is the femoral condyle, the little tiny sliver of bone, and this was the tibia from one of the condyles. And that is what the post-operative X-ray looked like, and it looked good on the laterals as well. The woman was able to stand up and come back to a functional lifestyle. But once again, I would like to emphasize, especially for the younger generation, the beginners, and still on the learning curve, I would advise you that if you have access to a hinge joint, if you have familiarity with putting in a hinge joint, this type of dramatically globally lax knees are better off done with a hinge joint rather than trying out something like this, because although it looks simple and clean as you go along this set of slides, but on table you might not be able to get your fine titration of that overall ligamentous structures of the entire capsular structures the way I luckily got away in this case. Okay. Now, more importantly, I would like quickly to show you one more case where actually it proves my point. Here,
by quickly, yeah.
Have I run out of time this quickly?
Yeah, it's quite a lot. Yeah.
Oh, right. Oh, really? I'm so sorry. Okay, just a tiny hint. I started off with a knee which looked innocent, except for the slight posterior capsule osteophytic formation, ossification. And later on, after doing the primary knee, I realized that it started going into hyperextension. To quickly come to the point, it was a neuropathic joint with an extremely little subtle hint. I missed out on that first time. I had put in a primary PS knee, which Hemant just suggested doing, and it looked absolutely fine the early. But as time passed by, and this is, I'm talking about hardly a year and a half, it went into hyperextension. And then I had to put in a hinge joint. And then in the hinge joint, the woman did well. So the point is, to conclude, diabetic patients are at high risk, important to keep high alertness, recognize neuropathy. I missed out on that second case that I showed you. Always use a fully constrained or a rotating hinge prosthesis. Anticipate a high complication rate. Prepare yourself and the patient for eventual arthrodesis if required. And arthroplasty does offer acceptable results and should not be rejected as an appropriate option in these patients. First go.
Thank you.
So thank you.
Thank you. That's quite elaborate. And Dhanashekhar, you've been waiting, my friend from Coimbatore, the champion surgeon from Coimbatore. He would be talking on the loose sunken primaries to build them or to cone them, and vice versa.
Yeah, thank you. Thank you, Vikash and IAA for the opportunity. And I'm going to talk about building the loose primaries. So in a revision TKA, you can have implant failure at loosening. It can be a mechanical failure or infection or a periprosthetic fracture or breakage of an implant. All these things result in bone loss, and also combined with particulate disease, there is a lot of bone loss, more than what we anticipate. The options include cementation alone, bone grafting, modular metal augments, metaphasial fixation. There are two types, metaphasial sleeves and cones, and a mega processes. So bone defect, we know the classification from Anderson Institute. It can be either a small contained defect or uncontained defect with a good cortex, or there is extensive bone loss with loss of cortex and ligament attachment loss. Cementation is very reliable and inexpensive, can be done if it is less than 5 millimeters. When there is more than 5 millimeters, we combine with the screw. This is an example where we have revised TKR. We have used cement to fill the defect in the epiphysis and metaphasial region because it's a contained defect. So this is an outcome without a major reconstruction requirement. Cement with screws, we have extensive experience during managing complex primary TKRs. So we always combine cement with screws if there is defect between 5 to 10 millimeters. So defect up to 20 millimeters can be managed with the addition of stem that resulted in good long-term outcome. Coming to bone grafting, we know we have a good source of bone graft when you're doing a primary. When there is a bone defect, we have the cut surface of the tibia and the femur. We used it to reconstruct the bone defect. But in case of revision, we either had to depend on impaction bone grafting technique or a structural bone graft. For that, we need to have access to a good bone bank. So impaction bone grafting is a little bit unpredictable, and availability of structural bone graft is a little bit difficult, and the incorporation also is unpredictable. So now we depend on other methods like metaphasial fixation and augmentation. So distal femoral augmentation generally used if there is a bone loss confined to the epiphysis. It can be either a distal or posterior augments. Usually we combine with other fixation methods like a stem. Tibial wedges also are useful. A full wedge or a hemi wedge can be used for a focal defect in the epiphysis or metaphysis. Example of use of tibial hemi wedge. In this case, there is a stress fracture distal to the implant and there is a medial collapse. We have used a medial hemi wedge combined with a long stem. So this is an example of a severe bone loss where we have used a metaphasial full wedge, tibial full wedge to increase the joint level so that we can restore the joint line accurately. This we used a hinge joint because the ligament attachment has been compromised due to extensive wear and bone loss. So here is an example of use of full wedge. But when you think about this, look at these fixations, you want a fixation in the metaphysis, not in the diaphysis. Both these fixations have been extended to the diaphysis. So if you want a fixation in the metaphysis, we need to have something different. So we are looking at metaphasial fixation. There are two options, porous titanium sleeves, which can be used in type 2 and type 3 defects. It improves construct stability and survival rate. And it has been proven clinical results. It gives axial and rotational stability. It fills the metaphasial defects. It can be alternating to a long stem. We can reduce the length of the stem required. The simple technique of broach, and then this is an example of an extensive medial defect in a primary. We are using a reamer to ream the canal and open up the canal. And this is a broach with which we use the prepare the metaphysis. Once we get a good press fit, we go ahead and put the final, this is how it looks. The entire cancellous bone is exposed and it is a good area to impact the sleeve. The sleeve, we can fix it independent of the stem and the tray. So it can be rotated and it will accommodate the defect, and we can reduce the length of the tray. We can fix it with the hybrid technique. The epiphyseal area, we can use the bone cement, and the metaphyseal area, we can do a uncemented fixation with the porous surface. We always combine the sleeve with the rotating platform design, which will decouple the forces across the joint so that the construct is not overloaded. And fixation if you are looking at the rotating platform design, we decouple the forces across the joint. This is an example of a femoral bone loss in a revision scenario. We have used uncemented fixation with a short stem in the femoral side and the fully cemented tibial sleeve on the tibial side. If you have a very small bone, especially in South Indian Asian patients, we have very small anatomy. So in those situations, we use a complete cemented fixation. This is an example of extensive medial collapse and bone loss in a 68-year-old female, 10 years post-surgery. We can see the extent of bone loss. So this is a preparation of the tibial sleeve. The defect is 20 millimeters from the top of the resected surface. So using a metaphasal sleeve to build up the defect. We are using a distal femoral augment to build up the distal femoral defect. This is the final construct. Tibial side uncemented fixation with the sleeve. On the femoral side, we have used the 8 mm distal femoral augment. So I'm doing more of uncemented fixation on the tibial side these days. One more example of an infected TKR where there is extensive bone loss. We can see the defect. I used a totally uncemented fixation in the tibial side. You can see how much defect we can build up with the sleeve. And this is the post-operative X-ray. This provided good fixation for this is almost like 4 years follow-up now. When there is a compromise of the collateral ligament, we need to go for a hinge type of processes. This is an example where the femoral side, the entire collateral attachment has been lost. We have to use a hinge type combined with the metaphasal sleeve and the rotating platform design. This is a post-operative X-ray with good reconstruction of the bone loss. Sometimes we need to revise our major MEHA processes, broken MEHA processes. Here I revised the femoral side with a tumor process, and the tibial side I did a conservative revision using a metaphasal sleeve. This is an example where there is a distal femoral fracture following a TKR. Patient come with loosening. I used a uncemented fixation on the femoral side with a long stem, and you can see the lateral view. The long stem with the metaphysis actually overcorrects the femoral bow. Instead of the normal femoral bow, it overcorrects. So it increases the posterior flexion instability. So this has to be avoided. So to avoid this scenarios, we can use a sleeve alone fixation without a stem. The bone stock is good. So this type of fixation is becoming popular now. So if you look at the long-term outcome, 10 years follow-up, the radiolucency has been seen in around 2.8% of the tibial and femoral sleeves at the end of 10 years follow-up. So now we have 10 years follow-up of these sleeves, and the outcome has been very good. So the other option are the porous tantalum cones, again are used in type 2 and type 3 defects, provides a structural and mechanical support. It provides immediate stability compared to sleeves. The cones can be directly impacted, and the stem, the implant can be cemented on these cones and gives excellent immediate stability. But problem is extraction is difficult. Sometimes you try to extract this due to infection. There is a chance of fracture of the host bone. Metaphasal cones are also available from other companies like Stryker. Now these are becoming more popular, and they're less expensive and are very useful. Mega processes are useful when there is extensive bone loss and it cannot be reconstructed. Like in this case of periprosthetic fracture, they are more expensive. If there is a risk of infection, the problem of treating infection is it's a major problem, and they'll end up in amputation.
Yeah.
The current trend is cementless metafacial fixation has been increasing in the US. The cemented fixation has been coming down. The tibial side, the uncemented fixation has gone up, and it has provided good stability. And thank you for the opportunity.
Yeah, I think thank you. Just above the time, but thank you. That was a very comprehensive lecture indeed. I think we don't have time much before we start our final lecture with our president, Dr. Rajiv Sharma, and he would be talking on the dislocated TKR, retain or revise, how and when. That's very specific, and I'm sure he'll be absolutely to the point, and then we'll discuss.
Thank you so much, Vikash, and it's a pleasure to be with all friends again, especially with Dr. Briard. I'll be speaking on dislocating or subluxating total knees, which is a major concern for any surgeon, because a mild instability patient may still have a problem of getting up from the chair or difficulty on taking stairs. But if there is a gross instability, it will give rise to the dislocation or a subluxating knee. How it happens? Mediolateral stress in extreme flexion coupled with the collateral ligament instability, and it will result in the pain, giving way episodes, joint effusion, and usually the reason is primarily large flexion gap or the unstable MCL or unstable LCL. What is the impact of the implant during dynamic activities and load bearing is very important to understand in this situation. Condylar geometry also gives some kind of a stability. Geometry of the post-cam mechanism is very important. At what degree of flexion it engages, what is the engagement velocity, jump height, and whether the post is correctly placed in that particular implant. And both have a role in minimizing the engagement velocity and forces stresses in the post. Post fracture can happen, attrition in the PCL in a CR knee. Now here the compare the Sigma implant, the PS implant, and the more constrained TC3 implant, and you can see that the box and cam both will be larger. But just having the larger cam, that the larger cam and larger post is not enough. The basic stability, in my mind, is very important, and that's what we will discuss and see in next few slides. Retain or revise, when you have a dislocation, it causes the worsened collateral stability, because the dislocated poly will give rise to more stretching of the ligaments, especially if the patient is walking on it. Here you see the primary total knee arthroplasty, mobile bearing joint in a very simple, it looks very fine, but at 2 months' time, that's what the patient sends to me, the pictures from his home. His knee is quite big, and the suspicion obviously will remain that whether we are dealing with the infection or what. But with the careful examination, you can understand that there is a stability, and that's what you see. You find in this patient, when you open up the joint, you see that the poly is totally rotated on the other side, and you can see that the anterior part has gone to posterior part, and that's how you work on it after the synovectomy and cleaning the joint. You see, you just put a pressure, and first you may bring the poly in a mobile bearing in the right position, and then you see that how this stability, you just assess the stability in this patient. That's what you see here. We use primarily 10 millimeter poly, and finally we could get away with just changing the poly itself, because the stability, we could achieve the stability just increasing the height of the poly by 7 millimeter, and we use the 17 millimeter poly, and you can see here that the joint looks stable. But what the problem patient will have? Patient will have a problem in extension, and patient is expected to have some amount of flexion deformity, so which can be dealt with very easily with using the knee immobilizer and stressing upon the right kind of the stretching of the knee. That's what you see in this patient. We could get away in this video is at, I think, about 2 months or 3 months post surgery, and you see that this patient is able to have a reasonable good extension. Another patient you see with the flexion deformity, and when you are dealing with a flexion deformity, be careful, because in a flexion deformity, the instability could be a major issue, because there is a primary mismatch between the extension and the flexion gap. And that's what this patient sends the X-ray to me from Afghanistan. And hopefully we will have to deal with this when he comes to our country. But you see that in this kind of a situation, you will have to revise the tibia for sure. And because he had a primary flexion deformity, we know that the extension gap will still be limited. So we might have to revise the femur as well in this situation. This patient is able to walk, but not with the confidence that the patient should be walking normally. A well-fixed component in an imbalanced joint is a major issue. And that's what you see here. You see that the cam is just posterior part. And that is why, because the flexion instability is too much. This patient was operated somewhere in Korea. The true flexion instability should not be confused with the mid-flexion instability, which is just the flexion instability in about 30-degree flexion. Removal of the implant carefully, and then what you see is that's what you see. You see that there is a large gap on the lateral side, and how you deal with this in a very easy way. My trick is that do more posterior release, increase the femoral component, bring the femoral component slightly down, use a one size larger femur and larger insert, and if possible, do the suturing of the lateral collateral ligament. And that's what you see, and you can get away with the PS knee with extension stems. That's what you see this patient's video. Huge laxity inflection. This is my very old surgery, about almost somewhere in 2000, 2001, when we were using the LCS knee in abundance, and that's what you see here. We reconstructed the middle collateral ligament using the hamstring. The joint was opened with the tibial tubercle osteotomy. The middle epicondylar osteotomy was done, and the hamstring was passed to the other side. The middle epicondyle was shifted slightly proximally. So a combination of all these efforts fixed finally with the screws, and this ligament worked very well. That's what we see here. That's what in the short, because of the shortage of time, I will not show the videos, but this joint was very stable. And the result that you see 4 years after reconstruction, that this patient is fully stable, able to walk well. And so far there is no instability, no loosening of the joint or further problem from the patient. In certain patients where you have the gross laxity, what Bharat has shown, the laxity is medial, laxity is lateral, and coupled with the infection. Now that's the problem, but it can also be advantage to us in sometimes. You clean up the joint, you see that there is a large mismatch in the flexion extension gap, but you use the cement in this, and the cement and reduce the gaps. The fibrosis that happens may also give rise to some kind of a stability. That's what we found in this patient. Joint opened with the tibial tubercle osteotomy, and you see that this patient was far more stable. But here you have to be very, very careful in dealing with the soft tissues, and that's what you see the result at 4 years. My message is that unstable knee needs to be addressed very carefully. If you feel that there is a gross instability, use a constraint implant for sure. And just don't trust on the constraint implant alone. Use the extension stems as well for added stability. Medial or lateral instability, both will be a problem for the subluxating or dislocating joint. Instability could be a major issue in treating the severe fixed flexion deformity, and be careful in these patients and use a constraint implant if it is needed. Thank you so much, Vikash.
Thank you. That was just slightly above time, but we are running late by about 12 minutes, but it's okay. I think that much of leeway some of our more experienced speakers have taken, and that's good also. We have got to learn a bit more. Anup was excellent in his video, and all of us should appreciate all the time constraints which people have, but they could have spoken much more. Now 10 minutes is what we have. I think Bharat Bhai was raring to go after the first talk. So there is something which is there in his mind, which I think would be addressed to Anup. Bharat Bhai, I think it's your question, which is waiting.
Sure. So what Anup obviously is a very talented and experienced surgeon. My point to him is, I mean, he demonstrated that for a varus knee, where the medial collateral ligament was a bit tight, but we do realize that our ligaments, there is a limit to what ligaments can contract. They are not like muscles. And after doing all that he did, he still had some residual lateral ligament laxity. It was the lateral ligament which was pathological. My submission to him is that if at all you want to, instead of going to a constrained type of an implant, if at all you wanted to do something with the soft tissues, would it not be far more logical to do an upslide of the lateral collateral ligament and make it tight rather than do a medial epicondylar osteotomy? And did you increase the thickness of your insert? Because just by letting the medial epicondyle slide back and posteriorly and inferiorly, it doesn't do anything about the laxity of the lateral side. So I presume that you increase the thickness to fill up the lateral gap, although you did not mention it in your lecture. Anup.
Yeah, so Bharat, if you had observed the navigation screen, it was not only the lateral laxities, but residual varus of 12 degrees. If you had seen the screen that I showed after doing everything, that is reduction, osteotomy, deep elevation of the medial collateral ligament, all of that we do to correct the varus, we are still left with 12 degrees of varus along with lateral laxity. So there are two issues, lateral laxity and residual varus. So medial epicondylar osteotomy addresses both. It opens up the medial side and simultaneously helps correct the alignment, which in turn tightens up the lateral structures.
So then did you use thicker insert?
Just one size up. So from 9, I went to 11. Now talking of the lateral advancement osteotomy, if you're mentioning why didn't you tighten the lateral side, that would not correct my varus deformity, because until and unless, just a minute, let me finish. Until and unless you do an osteotomy medially, you won't be able to correct the varus just by advancing the lateral side. And by advancing the lateral epicondyle, you would address the problem in extension, but you will make the gap tight in flexion, which will decrease the range of motion. So in case your overall deformity is corrected, Bharat, if your overall deformity is achieved, coronal alignment is achieved, but you have lateral laxity, that can be taken care by lateral advancement osteotomy. But a residual varus of 12 degrees, as I showed on the screen, needs osteotomy to correct not only the coronal alignment, but also the imbalance in extension.
Fair enough. I just wanted to point out that when you, I mean, I'm not referring to you who are experienced with navigation, but in general to the people who might be here in the audience, that when you use the navigation and when those charts show you a residual varus, remember that with laxity on lateral side is just the sheer positioning of the limbs which will register as a varus on the screen. It doesn't mean that it is a fixed varus. It could be a correctable varus.
It's a fixed
I mean, not Anup, you are not the, I know you would do everything perfect. So I'm just wanting to bring home that point that after doing so much of release, you started off with a, what was the varus that you started off with?
26.
So after 26 of varus, you still had a residual 11 because of pure tightness of a pathological nature on the medial side. And therefore you chose to go ahead, which is fair enough.
So,
your argument and logic is very.
If I can intervene here, would I get an opinion from Professor Dr. Bryard here on this particular situation?
Yeah, and in this case, I have finished to do a huge medial release because I found myself to do too much release. So I correct the varus deformity and I have residual lateral deformity. So for this case, I do a lateral sliding osteotomy and well, it's worked, but lateral.
So, Dr. Bryard, won't you be using navigation to check, as Dr. Anup has done, to be absolutely perfect on the coronal alignment and make it 1 degree or 2 degree in valgus, as navigated the best alignment?
Yeah, I used a lot navigation 20 years ago, and now I don't use it quite often. And
so would you, sorry, pardon me, would you err on the side of 2 to 3 degree of varus if you get a good balance on your knee, rather than getting a perfectly aligned navigated knee in this case?
Oh, I prefer to keep 2 degrees of varus if I start with a varus knee.
In a 26 degree varus, you would be okay with a 2-3 degree varus,
yes,
if it is well balanced.
Yeah.
So
we don't have a osteoporotic bone like you have, which may be important I'm afraid when I see you both in India or China keeping the deformity when you have so much osteoporosis.
It's brilliant for like a business.
Anup, could I ask a question? Now, you did everything, like you did a posterior middle release, undersized the tibia, removed the flare of the osteophytes, and then you did medial epicondyle osteotomy. You think you could have got that medial epicondyle osteotomy earlier in your sequence of releases? That would have, prevented all this soft tissue release and undersizing of the tibia.
Correct. So that's the question that Abhay also asked me, chat box. That
Quickly,
when do you decide what's your threshold to do a medial epicondylar osteotomy? So my threshold is downsizing the posterior medial release, but not the pie crusting, because if you do the pie crusting and then you are causing great instability. So you downsize You remove the flare, and if you still have more than 10-12 degree varus, then don't go for pie crusting, because pie crusting will just open up 2 or 3 millimeters. The difference here was 15. So that is the time when you decide that you have to do osteotomy, especially in a chronic subluxed knee, where 1/3 of the tibial condyle is under the femoral condyle. It's uncorrectable varus. That's the time that you decide to do a medial epicondyle.
We move on to the question to Hemant. Is Hemant here? Dr. Hemant, are you there? There is a question from Abhay. What makes you commit to a hinge in severe hyperextension knee? Would you like to take it, Dr. Bharat Modi? I think you have a similar.
In an hyperextension knee, I would strongly suggest to all the audience, including the experienced one here, that we might be better off depending on a hinge knee, despite the issues of that anterior block where, plastic wear out or the wear out at the hinge, the bushing, etc. With modern materials and the high quality of engineered implants that we have, you still will be able to provide your patient with a far more predictable outcome rather than try to do anything else. So I have become to the firm opinion that in an hyperextension knee, there's no point hoping that just by adjusting your bone cuts on table, you will get a sustainable, because we need to understand what is causing that hyperextension in the first place. It's a neuropathological issue with the overall format of that limb, and that is why it goes into that strange deformity. Why is it that almost all these humongous number of osteoarthritis that we see every day in our lives across the world, and that's an extremely tiny proportion which go into hyperextension the way they do, and almost all of them are eventually found to have some neuropathological things.
So what we are getting the message from you is that if at all you get a hyperextension or a slightly 2 or 3 different way loose knee, and you have primary osteoarthritis, you presume that this is a neuropathology, even if it is not proven. Is that what you are saying?
So you be paranoid about it and do your best to establish, including taking neurophysicians' opinion, do your nerve conduction studies, etc. The chances are you will find some hint somewhere, and if you have the tiniest of hint, a long-term predictable result is with a hinge in relative long-term, sort of here.
So you won't in a youngish 50s, you would not still go for a TC3 and you would straight away go for a hinge?
You can give TC3 a try, to be honest, because if you are in a very early phase of that entire cycle, but prepare the patient for a revision once again of a large, because the problem is once you take a TC3, you with a unstable knee, you will have to put your extender rods and everything, and then let's say in 6 years or 7 years, if they undergo once again a hyperextension problem, because TC3 has its limits. For example, a completely transected MCL cannot be compensated with a TC3.
That's out.
So that's what I'm saying. So yeah, we have to be a bit careful there.
So coming to the this valgus knees, Sanjeev, are you there? Sanjeev? So would anybody take any question on valgus knees here?
Yes, I'm there.
Yeah, Sanjeev. So why is there any special type of valgus knee which you would prefer to do a valgus exposure, or would you always? This is an off-track question from what you said, but that approach makes a difference of how you kind of go ahead and deal with that knee. Sometimes
the lateral approach has been described, but so far I have never done it, and we've been successful doing all kind of valgus knee with our routine medial parapetral approach.
Okay, and the next is that what would be your, you never in your talk, I think it was a lot about constraint in the knee, but what would be your approach to your cuts in a correctable hypervalgus knee?
See,
your bony
in
cuts.
any kind of valgus deformity, the bone cut, you should always take the lesser one, lesser side. Okay, because when you release it, definitely it's going to be, if you're not doing a CR knee, if you're doing a PS knee, then it's going to open up and you're going to be the problem in balancing the gaps. So it should always be, the bone cut should be definitely less in any situation in the valgus knee.
What I mean to say is, what would be your first distal femoral cut in a valgus knee? Say a 15-degree valgus knee or a 20-degree valgus knee, which is not correctable.
You're doing distal femoral cut. Distal femoral cut. So
Yes.
distally, not it cannot be more than you can say 5 degrees, not more than 5 degrees.
Is there any difference of opinion regarding rotation of femoral implant and the cut? Professor Breyer, do you have any take on this?
Well, for us, we look at the medial side. If you have laxity, I think then I do them from medially, and if the medial structures are good enough, I do my release, and I reconstruct the medial compartment. If the soft tissue are worth nothing, I think then it's a hinge. For the genivalgum with no medial laxity but very tight structures and 20 degrees valgus, then I do them from the lateral side, and I do lateral sliding osteotomy.
Okay, so that's from the champion of valgus knees, which we get to hear. And thank you. And I think, Dhanashekhar, would you mind just coming in on your threshold for deciding that just in one line after your lecture, when you would like to build up tibia, and when would you know immediately that you are going to cone them? Just in one line. Is there a radiological parameter or a post-open knee parameter? What you see? Dhanashekhar, are you there?
Yeah, pre-op X-ray assessment. If the bone loss is below the head of the fibula, I would like, on the both sides, I would like to directly go for a sleeve or cone. Yeah. Bone defect below the level of the fibula, both sides, it has to be a cone or a sleeve, which will provide a metaphase fixation.
So that means 1.5 centimeters or more of loss, tibial bone loss, which we are talking about.
Yes.
Right. So I think we are good to go. Last one, I think, for Dr. Rajiv. He has already made his point very clear that in both he has shown the cases where he could get away with without changing the knee, and he could get away later on. If he could not, he did the hinge. So I think those were quite good cases.
One statement that I'll like to make, that for our in any unstable joint, one part is that we use the constrained implant, but the very important part is that try to achieve as much stability of the collateral frame and the capsule as much possible, and then you should decide the level of the constraint you need.
Yeah, so we did see both the examples in your cases very nicely, and I think we would keep some more questions, and I would straight away, because of the time constraint, there is one question which is the last question, I think. When is it advisable to mobilize the patient with full weight bearing after surgery in instabilities of knee? Dr. Hariom Agarwal from Patiala. Anybody can take this. So, Dr. Rajiv.
See, if your stability is good of the implant and the soft tissues, then you need not give any immobilization. And if you have a suspicion that you have done an epicondylar osteotomy, then probably for a period of 3 weeks you should give the knee mobilizer in all the cases for walking. But on the bed you can leave the patient without the support.
Thank you.
For courses, yeah. So we quickly move on. We quickly move on. We'll keep the questions a bit next time. We have still some time to go. A lot of cases to come. So we have a case-based panel discussion coming up. The first case, do we have a friend Rakesh from Kolkata, my colleague, and wonderful arthroplasty surgeon? Rakesh, are you there? Can you share this? Yes.
I can, yeah.
Your case is of per-op MCL injury, and once you start screen sharing, your time would start.
Okay, I think you can start the time. So I was very happy to see that it's not just me who makes. I'm visible, Vikas?
If you are, your slide needs to open.
Is it not open yet?
No.
So all the speakers, case presenters, please
just check that. Is that open?
Yeah, it's open now. Yeah. Quickly.
Okay, I don't know whether it's the same one which I had prepared for this, but looks like the same one. So I was happy to see that it's not just me making this sort of a mess on the OT table. There are others who do the same. So the history is that this lady had 10 years ago a distal femur fracture. She's from Biratnagar in Nepal and had multiple surgeries. I think 3 at least, which I remember, on the distal femur to try heal with a distal femoral plate, DCS, I think they had been applied, but didn't heal. And by the time this plate was also infected when represented to us in about 10 years ago. So I first had to do 2-stage debridement, one with cement spacer, and then, immobilized. And then we had to come back and do, I used to do a lot of nails during those times. And even I still do nails for distal femurs. So I did a nail and then bone grafted. And luckily, even though there was a huge defect in the femur, the nail migrated laterally, but we managed to heal her. And she was fine for last 10 years. But she's now presented with severe pain on this side, mild pain on the other side, almost unable to walk on this side. Still has good range of movement, 0 to 95. That's her X-ray. And just have a casual look. She is in a fair amount of valgus as these shows. The other one, I think, is just in a neutral alignment. And the fracture is well healed. The question to me was, now she is heading towards a knee replacement. And what can I do? Do I need to take the nail out? Can I do something with the nail in? And we have erred towards a lot of these implants, trying to keep them and trying to do a TKR. So I templated and realized that if I do about a 7 cut, I might just about get away. However, on OT table, that's a flexion, and you can see all the scars which are beautifully healed though. So I had, I'm ready. I got all the equipment in case I need to take the nail out. So I'll just come back to this. So once we expose this patient, we realized there's a lot of scarring in this. So from here, we had to move very carefully. When I did the robotic assessment, it was asking me to do a 9 femoral cut, but I realized that if I do 9, then I have to fiddle around with the nail, which may be weaken my metaphysis, and then I may end up with lots of complicated surgeries here. So I erred towards the 7 mm distal femoral cut. But when we were doing the checking for the extension, I realized that I don't get the extension. So there was a lack of extension. And so I even burred the slight amount of nail which was protruding. But in the end, actually, I had to take the nail out. There was no other way because we had to move towards the 9 mm cut. And that's the balance which I found on the 9 mm cut. However, on 2 or 3 attempts when we made to check the balance, suddenly I saw the medial side opening up. And if you see here, now compared on the lateral and medial side, you can see the medial side has not only opened up, but it's beginning to rotate outside. And this clearly tells me that I have damaged the MCL. So I was looking at how did I damage this? The cuts were all done by this time. So where did the damage actually happen? And I realized that the bone here was so osteoporotic and weak that the actual MCL piece of bone around there was already beginning to avulse. So there was this small amount of MCL still attached, but the major part was beginning to avulse. So on table, then we made a decision that, you can't just go on just fixing this MCL on table because the bone quality was very poor and I wasn't prepared with the devices to fix this thing. So we are towards the same sequence of, I called in my sports injury colleague and we decided that we'll actually do the MCL reconstruction here. So we use the semitendinous graft here. So that's the graft we prepared here. We actually got both the grafts prepared. Eventually, we left the attachment where it is. Now, this is a question we can come back to answer. What should we do from the distal end? We found that the graft was good enough to actually go on the proximal end. So we moved on, and then because I knew that my initial template that the spaces I had was good enough, so we went ahead with our implantations. And then later on, we ended up fixing this graft on the femoral side, just where the MCL actually is. So this graft, once it was fixed in with the bias screw, we also used a swivel lock to actually lock in that small piece of bone which was avulsing with the MCL, so that we have the original MCL also there. And apart from just fixing with that, the swivel lock comes in with this fiber wire sutures. So we even use the sutures to actually tape all the MCL and the remnant MCL and the newly constructed MCL. So all that became a very good tissue for us to actually then go ahead and see a post-op X-ray. It may look valgus because of the deformity on the femur, but actually the alignment-wise on the robot we had only about 3 degrees of valgus. So we were quite happy with that one. That's how our 4-month X-ray looks like. That's her movement actually just 1 month, because this is lady from Nepal. She stayed with us for a month. And then here, this is her 6 months X-ray, where you can, the walking video, which you can see her, she's actually quite independent and quite comfortable with her knee. She can do independently sitting and standing actually on the couch. And so far, I think it's been very happy. And it's been seen from series that once you actually get a good result on table and mobilize in the beginning, overall the function of this MCL is good. We are actually even happier because we still have the original MCL also here, which might have healed by now. Thank you.
Perfect. Thank you, Rakesh. And we'll take all the questions and discussion later. Now we go to flexion instability case by our friend Krishna Kiran from Hyderabad, a brilliant surgeon and a great orator. Krishna, over to you.
Thank you, Vikas. Am I audible?
Yes, you are.
Yeah, so it's a short case. I think we have one more case by Manoj on the same this thing. So this was a 69-year-old doctor. He underwent a posterior stabilized total knee replacement about 6 months back and instability in the left knee. He was never happy with the knee. He had anterior knee pain and difficulty in descending the stairs. He had recurrent effusions and one episode of query subluxation, which was reduced in the previous hospital where he underwent the surgery. Clinical examination showed 10 degrees fixed flexion deformity of the knee and further range of motion up to 90 degrees. And these were the pre-operative X-rays. The patellar tracking was reasonable. And when we retrieved the data, we found that the polyethylene thickness which was used was around 18 millimeter and a PS plus poly was used in this particular case. And if you see here carefully, there is a tendency of this thing to subluxate back. So probably some issue with this flexion gap stability. So we took the anterior drawer stress radiographs and we found that there was a grade 3 laxity in the flexion. And the flexion deformity also suggested with an 18 millimeter poly that there was something wrong which happened with probably the flexion extension mismatch, which could not be addressed by the thicker polyethylene. So the symptoms of flexion instability were very, very classic: difficulty in descending stairs, the presence of anterior knee pain, paradoxically some residual flexion deformity, and the presence of a subjective sense of instability right from the day of surgery, all pointed to a significant flexion deformity. And when we assessed the radiograph, we felt that although the tibial slope was okay, probably the posterior condylar offset was not well restored in this particular case. And the patient was offered both conservative and revision surgeries, and he opted for a revision surgery because he was not happy with this particular knee. So when we did the assessment, the PS implant was Genesis, poly was 18 millimeter PS plus, which was largest available, which clearly pointed that something was not right on the table because it was a simple varus knee to start with. We believe that inadequate restoration of the posterior condylar offset was probably the cause. Grade 3 anterior translation of tibia on stress radiographs as we showed. And since the patellar tracking was adequate, we did not do a CT scan to look for the component rotation. Of course, we had to rule out infection because of symptoms from day one, and ESR, CRP were normal. The plan was removal of previous implants and revision with metaphyseal sleeves to TC3. And we kept a hinge standby if at all we were not able to equalize the extension and flexion gaps intraoperatively. As we all know, flexion instability, where we are not able to equalize the extension and flexion gaps, is probably an indication for higher constraint and, if required, a hinge replacement. So these were the intraoperative videos. You can see that the knee was actually dislocated, and you can see that the flexion space was so much that the cam was subluxating back out of the knee. So this was what was happening. where there were episodes of repeated subluxation and relocation of the knee, and the knee was so lax in flexion. And you can see that the anterior translation is almost grade 3 for the patient. So what were the intraoperative strategies we used? We removed the implants with minimal bone loss. Manoj will focus on how to do this. We used a tibial sleeve to proximalize the resection level because 18 millimeter poly was used. We did not want to use a bigger polyethylene because we know that any poly which is more than 17.5 has got higher risk of early revisions because of instability. So we used a tibial sleeve to proximalize the resection level on the tibia and reduce the tibial slope. We upsized the femoral component and flexed it using the metaphyseal sleeve. So if you restore the anterior bow and use the metaphyseal sleeve appropriately, Dhanasekar was pointing out to this, you can flex the femoral component and stuff the flexion gap, which we wanted to do. We balanced the flexion gap and did some additional distal resection to match the extension gap to the flexion gap. So these were the strategies which we followed. And this is what we were able to achieve. You can observe that the metaphyseal sleeve is flexed a little bit. A word of caution while using femoral metaphyseal sleeves is that you must have circumferential contact with bone on the distal femoral processes, because this is a taper lock mechanism. And if you don't have a complete contact either with the use of distal posterior augments or with the use of some sort of a graft with the distal femur, all the load will fall on the taper and the trunnion interface between the metaphyseal sleeve and the femur, and it will break there in the midterm. On the tibial side, it's a stem-in sleeve construct, so there is not that much of a problem. So this particular point must be kept in mind while using the femoral metaphyseal sleeves. You can see we've used the femoral metaphyseal sleeve to proximalize the joint resection level and to neutralize the slope which was used. So it's almost a neutral slope. If upsize the femoral component and flex the metaphyseal sleeve to stop the flexion gap. And with a 17.5 millimeter TC3 poly, we were able to equalize the flexion extension gap. And this is a 2-year follow-up X-ray showing good outcome and a stable implant, and the patient is happy. And we used a hybrid type of fixation and with cementing on the epiphyseal area and uncemmented on the metaphyseas. And one word about the use of metaphyseal sleeve here. The tibial stem must not be a press fit stem. It will prevent seating of the metaphyseal sleeve. You must use one size smaller than what you ream on the tibia to avoid engaging distally and then failure proximally. So this patient is doing well, and a case of flexion instability, which was managed by increasing the level of constraint and metaphyseal sleeves. Thank you.
Wonderful. It's such a lucid elucidation of these implants and their characteristics. Wonderful, Krishna. Well done. And now I have my friend Manoj Wadhwa, the champion surgeon from Chandigarh, who will be talking on the case of flexion instability with well-fixed implant, something which is an extension of what Krishna already spoke on. Manoj.
Thanks, Vikas, and thanks, Krishna, for keeping the ball rolling for flexion instability. This is a bit of a variation of flexion instability with well-fixed implant. I don't know, my slide is just, I'll share up my screen again. So these are my disclosures. So 77-year-old female with the bilateral knee replacement done elsewhere 2 years back. What history she gave was instability and unable to bear weight on the right side few days after surgery. Was given knee immobilizer for 4 weeks by the surgeon for the index surgery. When she started loading in, she had the same problem, persisted and could not walk. When she presented to us, she was wheelchair bound from last 2 years' time. Clinically, she had no swelling or edema, but she had a fixed extension deformity of 30 degrees on the right side, and maximum bending was up to 80 degrees. There were no signs of infection. Neurology was normal. Infective markers were normal. Clinically, she had instability both in the coronal and sagittal planes. Was unable to extend. What is happening?
No, you're good. Carry on.
So unable to extend the leg and movements were not painful. So on radiology, she had a total dislocated knee. And this was continuing from last 2 years' time. Now, a closer look to it, we found that she had a restorative TKR with well-fixed implants, and we had to move in for this surgery. The probable reasons we thought of for this dislocation was maybe that she has a late rupture of PCL because she had a CR knee done at that time. Maybe the PCL balancing was not appropriate, or maybe a thinner poly was used in the index surgery. But what we found was she also had excessive posterior slope of the tibia. This is where the tibia has to come on. But she was running us around, say, 13 or 14 degrees of posterior tibial slope, which can be one of the probable reasons for her dislocation. So we went inside and this knee was totally locked up. So for last 2 years, there's extensive amount of a fibrosis. And this is the extension and flexion views. Now, a very important part for all the junior listeners out here, subluxating this tibia forward is never going to be easy because it's a totally locked in stuff, and you have to be very, very careful because if you put up a spike at the back, you might have a neurovascular impalement. So go gradually move back in, excise the PCL from the femoral side. Once you get space in, move your lever onto the tibial poly and gradually start subluxating it forward. After some efforts, you are able to bring it forward, but as you can see out here, she had an immense flexion instability, huge amount of flexion gap that you see out there. If it would have been a case of a pure thinner poly being used, we would have stuffed it with a bigger poly. But in this particular case, A, she had a CR knee done before, and which had to be transitioned to a PS in this. B was a fact that she had a very high amount of a tibial slope. So we decided to sort of redo the entire surgery with the revision implants. So as you can see out here on the right picture is my saw blade showing in, and she had an excessive amount of a tibial posterior slope in her index surgery, which when corrected, we were able to come off with majority of the issues in this surgery. This is what I'm trying to illustrate as one of the probable reasons why she failed across initially in her index surgery. Once the cuts were made appropriate on the tibia and the femur, we used partially varus versus and knee, and with a PS, simple PS insert, we were able to give her a good deal of a flexion extension gap balance and range of motion 0 to 125 degrees. This was the total alignment in flexion as well as extension. And this is how she looked like on radiologically, perfectly aligned. So the carry-home message for these things is that flexion extension gap, like we keep saying in every primary, is the optimal part. If you're doing a CR knee, your PCL needs to be well titrated. Excessive tibial posterior slope has to be avoided in CR knees. And whenever you're handling very old dislocated posterior dislocations, be very careful to preserve the neurovascular structures. And thank you so much for assisting with us.
Thank you. Thanks. That was very well timed, excellently presented. And now we have a friend, Vijay, the champion hip surgeon, talking about one of the difficultly understood topics in knee replacement surgery, the mid-flexion instability. We all have this, and we all have gone wrong on this sometime. And Vijay, I would leave it to you. Vijay.
Yeah, thanks very much, Vikash, for the opportunity. Can you see my slides?
Yes, we can.
Right, okay. So my thing is talk on mid-flexion instability. Thanks to Krishna and Manoj for talking about flexion instability. So I think Kelly Vince hit the nail on the head when he called mid-flexion instability as woolly thinking. And woolly thinking is not a term that's commonly used in India. So woolly thinking refers to the art of thinking their head full of clouds, not clear thoughts, but rather done through the midst of not concentrating what you're doing. It also mean wandering from one idea to another. And sometimes, you sort of say words to confuse the people who are listening. So all this, is very true of mid-flexion instability, and sort of a basement diagnosis. When we don't know what's happening, people usually call it as mid-flexion instability. So it's like, in a hip X-ray, everything looks normal, and somebody wants to know what's abnormal. You say the anti-inclination is normal. Nobody knows what it is. They just put in some high-sounding words. So both Manoj and Krishna told about the flexion instability. So we have an extreme range of flexion that's regained very quickly after surgery. Knee never felt all right from start. Trigger spots all around the knee. Not patient doesn't trust the knee. The feeling of instability when loaded in flexion, climbing stairs, etc. Recurrent effusions, feels better with knee support. Classical constellation, and the classical signs of examination have been examined. The tibia must be not touching the ground but hanging. Then you do an anterior drawer, modified anterior drawer. Also, you'll find that the quadriceps contracts because the tibia is not touching the femur. The tibia moves upward before it contracts the femur and extends. This you can also see very well in clinical examination of a flexion instability. That we all know very well. This is the classical constellation of symptoms. Now, whenever both the speakers said about flexion instability, these are things that you look for. You have excessive posterior collar resection, so posterior joint line is elevated. There's a lack of posterior offset. There's a high posterior slope, like Manoj's case showed, and there may be stuffing of the femur. If you have, you don't resect enough of the femur, and you develop, and you can see a patella alta. These are all signs of. I am just reiterating the signs of flexion instability. So here's my case: a 57-year-old gentleman who actually runs a large tailoring shop. He's 2 years post TKR. He feels uncomfortable right from start. Very unhappy with the knee. Pain is present, anti-knee pain, difficulty climbing stairs, intermittent swelling is there. The trigger spots, the pes anseline area. He extends fully, unlike the other two cases presented. Now note that the flexion isn't great. It's about 125. Mid-laterally it is stable. He feels better. So all his classical signs of a flexion instability is there. His ESR and CRP is normal, and the CT profile for rotation profile is normal. So you'd think that classically flexion instability. However, on clinical examination, you find that there is anterior drawer is negative, and the classical Kelly-Win sign, as we now call it, is absent, and indicating that maybe it's not a flexion instability. So we have to look at X-rays closely, and we look at the X-rays, we find that you would expect to have a posterior slope or an exaggerated posterior slope in a flexion instability. Here is a reversal of slope. Patient has got flexion instability signs, but reversal of slope. You'd expect the posterior offset to be low, but here it is equal. There's no deficiency of posterior offset or no elevation on the posterior joint line. And here you can find that instead of having a patella alta, there's actually a patella baja. Yeah. So you think that just doesn't add up. There's some mismatch here going on. So what's happening here? So this is the classical mid-flexion instability that we now beginning to understand more and more. It's not a basement diagnosis anymore. It's really a precise diagnosis that one has to make. So these are the pair of findings during the surgery. You can see that in full extension, with the posterior capsule being stretched, there is no medial lateral laxity. But once it comes to slight bit of flexion, 30 degrees, it starts showing the signs of. And also you'll see that medial laterally, it's not that stable once you bend it a little bit. It starts showing the laxity. It's more subtle than flexion instability, but it is not flexion instability. And this is during the revision surgery. We have done quite a conservative revision. We have put distal augments on the femur, and that's the post-op X-ray. That's the 1 year follow-up, and that's the 3 year follow-up of the case. He's doing very well. He's very happy following the revision surgery. 3 years follow-up now. Now, mid-flexion instability is classically described in these three scenarios. Stryker always tells us that when you use a non-single radius design, you are prone for mid-flexion stability. But these days, all the modern designs do not have that problem. All modern are safe from so-called mid-flexion instabilities. That's not the problem. If you proximalize the femur, elevate the joint line, that's when you're really asking for instability. If you injure the MCL or you release some fibers of the MCL, not the entire MCL, but defunction some fibers, the critical in that phase of flexion, the stability in that phase of flexion, then you get mid-flexion instability. These are classically described three scenarios, which we have to be careful about. So the importance of mid-flexion instability is that it is not flexion instability at all. A lot of people think it is early flexion instability. It is not. The causes are opposite that of flexion instability. That's the point I want to make. It's exactly the opposite of flexion instability. Symptoms of flexion instability are there, but different entity with different management. Clinical findings are different. Radiology is different. Every surgeon must be aware of this entity for diagnosis and subsequent management. Must have a clear understanding of the same. So it is not flexion instability. It is opposite of flexion instability. So I'd like to end by saying, if you really think about it, it's actually subtle extension instability, because when the without hyperextension, subtle, gross extension instability will cause hyperextension. Here it's subtle and manifests only when the posterior capsule is taken off by flexion. Then it manifests. So please don't be under the impression just because called as mid-flexion, it is a subtle form of flexion instability. No, it's not a subtle form. It's actually the opposite of flexion instability. So I thank you for your attention. Thanks very much.
Wow, that was absolutely expected from you, Vijay. Such a wonderful talk as usual. Thank you very much. It is more of a talk than a case, but we are really thankful to you for showing it so nicely. And now we have a case of post-TKR subluxation by our friend Ashit Shah from Mumbai.
Right. Okay. So now let me just see. Where is my presentation? Yes. Good evening, friends. Thank you, Rajiv and Vikas, for this opportunity. Can you see my screen?
Yes, we can.
Okay. Right. Right. Okay.
Right.
What's happening? It's not going further. Okay, right. So I have this lady who is 65-year-old and presented to me in 2010. She had bilateral severe knee pain, classical bilateral osteoarthritis with varus deformity, non-diabetic, hypertensive on medication, no other medical issues. So what we did a bilateral one-stage total knee replacement. This is the rotating platform total knee from DePuy, left and right done at the same time. Uneventful post-op recovery. She is a community ambulator. 5 years, absolutely no problem. She never came back to me after initial 3-4 follow-ups, which is normally scheduled for a year. In October 2015, that is 5 years after the surgery, she fell on a wet floor and had severe pain in the right knee, could not get up, could not walk. Knee was stiff and could not move the knee at all. I have missed the x-rays where they are, but however, I took her to the operating room next day, keeping all the instruments and equipment ready. And this is how it was. I removed that poly and put the same size trial poly inside. And the knee is in extension, maybe a couple of 2 degrees of hyperextension. And this is the same poly, but the trial one. And if you see, it's completely loose inflection. This was 5 years after the surgery. However, both femur and tibia were very well aligned, well fixed. So what we did was, we did a thicker polyethylene insert. This was 15 millimeter poly, and it stopped my anterior posterior laxity, and it was stable in about 90 degrees of flexion, and also in about 40 degrees of flexion and in full extension. So we thought about it that both the femoral tibial components are well fixed, and with the symmetrical instability, inflection and extension with a higher poly, which is one of the indication of doing isolated poly exchange, this is what was done. And this is the final poly insert that was done. And patient was fine. This is the post-op x-rays on the right side. As you can see, is a higher poly used more, and the rest of the implants are fine. Isolated poly exchange, symmetrical instability, polyethylene wear, stiffness and arthropfibrosis, early PJI. These are the main indications of doing IPE. Patient made good recovery. In December 2019, that is 4 years after this surgery, she felt something moved in the knee, could not get up or stand, knee felt deformed and locked. And these were the x-rays in 2019. She was obviously admitted in emergency, and this is what was found. As I think so, Manoj and Kiran, they have mentioned, this poly was completely moved and it had become turned posterior to anterior. So the posterior portion of the poly was in front and it was facing actually backwards. As you can see here, the video with the dislocated poly. Completely loose knee. So at this point, obviously, we had to decide and do a complete revision, and we did a hinge. This is from the rotating hinge. We restored the collateral ligaments length, and we got this hinge prosthesis in. And this is how she is about 2 weeks post-op when my nurse goes home for the suture removal, and this is how she is walking. So now it is about 2.5 years since the surgery. I have not heard from her because it's a COVID and all that. But last when I heard from her relative, she was doing well. That was about a year ago. So should I have approached this case differently in 2015 when I did the IPE? And should we be doing anything to the left knee, because that is also going slightly in hyperextension clinically? So these are the two questions that I wanted to ask.
Yes, I think we will come to these two questions at the end of the case presentation. We have 3 more to go. And of course, I also have some questions. So now we go to dislocation knee with revision. Professor Ramesh Sen, who is our IOA president, and we are honored to have him on board presenting a case amongst us.
Thank you,
Professor
Dr.
Sen.
Vikash and Dr. Rajiv. So I'm just looking at the things which have been told by Manoj also, and right now in the last case also. When we talk about dislocation as such, we understand this is just a slide to show this is 3.3% of the revisions are due to this dislocation. Mostly we get posterior dislocation, sometime rarely, and probably on the table when we get it, though it is said that the mean age is 68, BMI is 33, meaning by they're fatty and they're mostly females. But if you look at the causes otherwise, they're mostly intraoperative causes, which could be malposition. Again, we are coming back to the same flexion extension, gap mismatch, PCL rupture in a CR knee like that. There are all things. So I'm here with the patient who is 60 years old, had a significant varus. First, I could not get his X-rays from the previous place where the surgery was done. But if you can look at that X-ray, which I could get from their history, was there is a big probably graft pain. You can see the positioning of the component also. And it is for 1 year, because within a month of the surgery, there was a problem of instability which patient has got. He got swelling also, but there was nothing of infection kind. And he has been using a brace and has been walking with that dislocated knee for full 1 year. So it is 1 year and 2 months or something like that. So we were a little suspicious about, we thought it could be some level of, because his CRP index was a little high. So we went for culture from the aspirate also. It was tried both the time. And you can see, he was, now the brace is out. So he is able to have a reasonable amount of a movement in that dislocated position. And when we were passively stretching, I forgot to show that on an image, it was passively hyperextended also. So the question was that if this is the kind of the situation, that way it was back and it was reducing also. So once we were putting it up, it was reducing also in this kind of a situation. And it was grossly unstable on that kind of a thing. So we again aspirated at the time of surgery and again sent it out. But what was there, it was easily coming in the front also, just like in the previous case of the Ashitason, it was going back. Then we tried to stretch it out, but medial collateral ligament has totally gone, and the lateral was also lax reasonably. So it was a grossly very loose knee, so we did not have a problem. So we initially thought that we might be able to increase the size, but it was such a loose thing. And because of the preoperative workup, we were there that probably we are likely to get up in a hinge joint. So we prepared for that. We took that, and you can see the cement etc. was quite normal. This was not gone much. There was not much of strain. So we could get that this tibial thing out. We could get this femur thing out also. And then we could get to this rotating hinge on that level once we were able to stabilize. And you can see the kind of spacer we had to use in this kind of a hinge also. It was significantly a big spacer over there. I don't remember the size exactly. So we use this noise hinge over at that place. So now with this kind of a displacement, so this is 1 month follow-up, and you see at 1 month follow-up also, he was flexing his knee to almost full degree at that stage also. He was able to walk around. And this is him after 3 months of follow-up. This is the implant over there. We use this thing also, implant where we had to use this thing to save the bone over here. Is this thing, and likewise here also, this is what we did from this thing. And then he could sit, he could stand, he's able to put up this thing also, a reasonable amount of strength. And this was the walking after about 3 months of follow-up. And his range of movement is too much, though quadriceps were relatively weak, his everything was okay. And then just called in the February when I had to have this thing. So I was not very comfortable with the patellar positioning over here at this point, because this was probably not getting balanced very well and this kind of a thing. But otherwise, it was okay. And his walking was a little not very comfortable kind of a walking with that also. You can see it out. Though he's comfortable, he doesn't have a problem. He complained little of the swelling at the leg as such, but we don't see that much of it. He's walking, he's comfortable, and he came because I called him for this presentation. So this patella, then we started to look at his clinically it was okay, but at that point of fixation, it was getting probably rotated to an extent. So that was the problem which I had in this case. So when you look at it, basically we look at the diagnosis causes, we have already talked about it. If it is dislocated like this, people had done under close reduction, that is for the acute situations they have done, and they have put a plaster also, it has settled down. And if there is a CR knee done, as Dr. Manoj also showed, you change over to a PS knee, and probably you are likely to go with that kind of a situation. This is the case published over there. And once we have got the insert going out, again you can see that polyethylene insert has duplicated and reversed. Here it was said in this paper that probably it was put in the other way around, but probably this must be the same case as was talked in the previous cases also, that it has probably rotated during that part. But in these cases, they have increased and they have changed the insert also. So this kind of instability, we had enough of lecture that they could be multifactorial. And in this situation, when the person has been walking, putting weight on that knee with the brace, it has actually stretched all the ligaments around, and probably we have there is no other option but to put a hinge kind of a joint in this situation. So there, but I am definitely not comfortable about the way the patella is looking like. Thank you.
Thank you very much, sir. That was again a very strong proposition for a hinge knee implant and complete stability in dislocations. So now we have two more left to go. Dr. Narayan Hulse will join us from Bengaluru, and he would talk about secondary instability due to catastrophic polywear. And he is Director of Orthopedics of Fortis Bangalore. Welcome, Dr. Narayan.
Good evening, everybody, and thanks for having me here today, IAA. My talk is a couple of small cases only, not much of any slides. So 68-year-old mother of a gynecologist had a bilateral knee replacement 4 years ago, and she was never happy with her right knee. This is the latest X-ray, but I don't have the original X-rays with the patient, but she was never been happy with that knee since the operation. She had on and off swelling and difficulty in her walking. She also tells to me that compared to her left knee, the right knee was little bent, giving us an idea that she continued to have that varus deformity in her right knee. On examination 0 to 120, it was quite lax, drier, both posterior and anterior were positive. It was in varus, as I said. It was also it was lax medial side. Now, this is an intra-op picture video. However, it is like a clinical examination for us to see. You can see quite a lot of instability, both in valgus and varus direction, and a little bit of hyperextension as well. Now, these are the X-rays. You can see a stress view on the lateral view. There is some subluxation of the tibia forward or the distal femur backward. Initially, we had a suspicion of a chronic infection. ESR was 21, CRP 7, and the knee aspiration didn't yield anything. So we have not proceeded further with the bone scan or CT, thinking that it is not an infective situation. So what are the options we have for this kind of situation with an instability with all the gadgets in? Obviously, we'll have to revise the situation. Can we salvage this situation only with an isolated poly exchange, partial revision, or constraint with the full revision if needed? However, see, when we went in, we saw a lot of metallosis. The black synovitis is everywhere in the suprapatellar region and all around. And what we could see was amazing destruction of the posteromedial part of the poly, and also the femur rubbing onto the tibial base plate, where even the tibial base plate is completely eroded on the posteromedial corner. So this catastrophic wear within 4 years was something which was unexpected on table. So these were the pictures of the removed implant. And once we have removed this implant, and we could preserve all the bones, distal femur and proximal, and we could do a simple revision. And you can see on table a flexion and a nicely balanced knee. And this is the immediate post-operative X-ray. And this is about a couple of years since the surgery. She's doing well and a good X-ray. And this is a triathlon revision from Stryker. So what was the reason? Most likely reason probably is an imbalanced knee. And probably there was a very high degree of uncorrected varus deformity, which has led to a progressive stretching on the loose lateral compartment that has put a lot of pressure on the poly and led to a catastrophic wear. Usually in the new poly, it is not common, and it used to be more common with less than 6 mm poly. The one which was in this knee, which is a 10 mm poly, it was a PS knee. So the secondary instability, which can confuse us during these kind of situation, is when you have a poly wear, metal wear, or an implant loosening, which presents something like instability, but actual situation is something different. Another patient had, within 2 years, had a fall, and when we opened, it was a break of the post of the poly, and it was just managed with a simple poly exchange only, rather than complete revision. Thank you very much.
That's wonderful. That's very nicely shown. 2 new cases, different perspective. And now we have the final assault by Mrinal from Delhi, and he'll talk on global instability with loose implants. And I think this would kind of cover everything which we would have in instability repertoire. So Dr. Mrinal Sharma,
thank you, Dr. Vikas and Dr. Ajit, for giving me this opportunity. I think Dr. Hulse needs to stop sharing his screen.
Stop, already stop.
Yeah.
Oui, on file.
Puis j'irai te rechercher.
Ah ben oui, voilà, j'y vais à pied. Bon, allez, je te laisse.
So, can you see my screen?
Yes, yes, we can.
Yeah, so I'll be speaking on global instability post-component loosening. She's a 68-year female, operated in 2017, and she presented to me with limp and progressive difficulty in walking for the past 6 months. Her infection workup was normal and aspiration was negative. ESR was 36, CRP was less than 5, within the range. When she came to me, these were her X-rays. You can see on the left X-ray, there is a progressive femoral component loosening. The tibia seems to be well fixed. And I advised her for a revision, and she did not agree. And 6 months down the line, she came with further loosening. Meanwhile, she had kept walking on that knee without a brace, or with a brace, did not follow the instructions. And this is how she comes to me during the, when I prepare her for the OT. This is the gross medial lateral laxity she has. And even you can see on the flexion, she has gross laxity. So it's a global laxity. All along, there is laxity in the medial lateral and the anterior posterior plane. And I had to decide what components to be used, and how to address the defects, if any, and what was ligamentous competency intraoperatively that would actually decide. So we were dealing with 2 things: component loosening due to probably aseptic loosening, and as infection work was normal, and global instability, which needed to be addressed. So this classification by Ridian, Jones, and Greichen told us that there are 3 kinds of instabilities that the problems we see. Type 1 is a bone deficiency only, type 2 is ligamentous and soft tissue deficiency, and type 3 is a composite one. So I was expecting all 2 of these, the type 3 in this patient, and the management could have been probably a thicker poly if the implants were not loose, and revision to a varus valgus constraint or a TC3, and all obviously keeping a hinged prosthesis and in hand. So intraoperatively, you can see this is all the, the implant could easily come out. The femur was almost loose. You can see there's no cement attached, no bone loss there. And the tibia was well fixed. I had to use the stacked osteotomy technique to take it out. And this is the femoral and the tibial component without any bone loss at all. And but intraoperatively, I found out that the medial femoral condyle had a defect on the posterior side, and it had to be rebuilt. I decided to go on with the TC3 with the posterior augmenter and rebuild all the defect. And also, I could find out that the intraoperatively the ligaments were components, so I decided to go on with the TC3 rather than a hinge, and I was able to balance the knee. So these are the post-op X-rays, and this is the intraoperative video. You can see the trialing being done, and it's balanced inflection and extension. And this is a 1-year follow-up of the same patient. So the take-home message was to rule out infection, reconstruct the bone defects, increase the constraint level up from what had been used earlier, and hinge in cases with gross mismatch if you're not able to balance, or there is still instability after, or ligamentous discontinuity intraoperatively. The case is open for discussion.
Thank you. That brings us to the end of the case discussions and case presentations. And now it's open for, all the cases are open for discussion. And we have a good 10 to 15 minutes, which if all of us want to extend beyond that also, since we have been able to finish reasonably well in time, within 2 hours or a bit more. So anybody would like to kind of add on to whatever they presented in their cases?
Can I take the questions Ashit asked? Yeah, whether you do the isolated poly exchange and then you did the hinge knee later on. I think after our understanding of instability more and more, there's only one role for isolated poly exchange. That's an acute setting. We find that you are not balanced medially or laterally, and you find the post-op X-ray, either the medial space or the lateral space is more than the other space. And then you can go in, release the correct structure, put a thicker poly. When you have a chronic scenario like in his case, if you're just going to do isolated poly exchange, you're just going to later on lead it further instability. It becomes more complex. Just like shoulder, multiple dislocations you have, the more complex instability. So you have to up the constraint. You have to either increase the posterior offset, you have to displace the femur, you have to do whatever is necessary. Just doing a poly exchange will never work in chronic cases. Please do not fall into this trap. Yeah, that would be my.
So in my case, she was never symptomatic for 5 years. After the primary knee, which was done in 2010. Till 2015, when that incident happened, she never had any problems. So it was difficult for me to believe that time that she has some malalignment or some ligament insufficiency at that time. So that's the reason I did that isolated poly exchange. And then again, 4 years went with that isolated poly exchange.
Yeah,
it was not immediate.
There's a sequence developing. Instability doesn't present overnight. So there's progressively in the instability. But as a message to the juniors, I find a lot of people doing isolated poly exchanges whenever they encounter any kind of instability. We have talked about instability in detail today, but the message is very limited role for an isolated poly exchange. If something else going on, find out what it is and you're going to address that.
Can I add a few words here, Vikas?
No, it's okay.
Continuing with what Vijay has mentioned very rightly, my view is that if the collateral ligaments are not insufficient, there is no laxity, medial or lateral, and the poly exchange is possible. But you must see the femur, especially in the heavier patients, the pull up the femur proximally, 1% or 2% can lift up the femur and then see under traction, because the flexion instability will be more visible under traction than just we are flexing the knee joint. And I think that will give us a better understanding of the stability of the joint. Dr. Brayard, what's your opinion on this? Because Brayard has been using a thigh lifter for a very long time. Janvi, what would be your opinion on this? Because the instability in flexion is a major issue.
Yeah, and I think that flexion test is good because, well, with the support that I use, I can see it perfectly.
Right.
But it's another way of working.
Can I ask a question here, Vikas?
Yes.
With all the faculty, just to keep the ball rolling. What is the level? What is the level of flexion extension gap mismatch that you are accepting in your joints? If you are doing a fixed bearing joint or if you are doing a mobile bearing joint, do you keep flexion and extension same, or do you propose a difference between the flexion and extension gap? And finally, let us ask Dr. Briard on this.
Where is Anup?
Yeah, I'm here.
You need to speak up.
Anup, what is the flexion and extension gaps that you accept, you aim for in your patients?
I would like to keep my flexion gap slightly loose, not to the level of instability, but just slightly loose so that the patient gets great range of motion.
Would you like to say how many millimeters for the audience?
Maybe because I use technology, either navigation or robotics, so
Yeah,
I would just like a millimeter, just a millimeter, not more than that. So suppose the extension space is 9, I would like to keep it 9.5 or 10 in flexion.
I would like to keep it equal. I will more than 2 certainly I will not accept, but my aim is if at all my flexion space to be slightly tighter than my extension space.
Then the patient patient has to do immense amount of physiotherapy to get range of motion.
Well,
Vijay,
you're protecting yourself against revision surgery, Anup.
Yeah.
Dr. Ranawat has been saying that flexion gap should be slightly tighter, or at least the equal. And he says that the post and cam will guide the flexion, especially when he started with the mobile bearing joints. Dr. Briard, what is your opinion on this?
Well, I think I like to have them tight in flexion. That means, well, nearly 0. I aim this. And, well, you know, in India, you don't have the same patient as we have. They are more loose.
Yeah.
And I get better flexion in India or Thailand. So I think the soft tissues are different.
So
I would like to add up
coming
here.
to the types of knees, rotating platform, a single radius design, a J-curve knee, which all of us use. Would there be a difference in this philosophy of flexion extension gap match or mismatch?
Oh, I use most of my life mobile bearings. So I try to have them well tight, but well, the soft tissues are different. I don't think that you can do what we do because they are tighter.
So Vijay, have you understood my question?
Yes, I've very rarely used mobile bearings, so I can't comment on that. Use fixed bearing always. So as I said, and nowadays, although they say multi-radius design, it's not that multi-radius as they used to be. So we don't see these problems that often. So flexion, I want to be equal to my extension, and if at all something has to be tighter, it has to be the flexion.
So that's a direct sort of.
I have one thing to add here. It is not do less with a sort of a fixed platform or a mobile platform. It is more to do with the philosophy or of a CR versus a PS. Right. I use 99% of my CR. In CR, by default, you have a millimeter or so tight flexion than the extension because that's what CR needs are. And if you keep them very lax or neutral, they would have a flexion instability. So when you do a PS, what Anup also said, from a 0 to 1 degree extra on the flexion is okay. But in a CR knee, normally you always have a flexion gap, which will either be equal or a millimeter tighter than extension.
Okay. Okay. So is there any comment on CR or PS, Professor Briard?
CR, we don't want them too tight because you have the posterior limb and they will wear, like the case we have seen. So CR are very, well, you have to be very careful with CR.
So would you leave it a millimeter loose in flexion?
Yeah, 1 millimeter, but not more. Yeah.
Vijay? Vijay, any change in your opinion?
Manoj.
Manoj, Vijay, anything?
Yeah. So the symptoms of instability are same, whether it is extension instability, and the patient doesn't like the knee, they are not confident, they like to wear a brace, they have repeated effusions, they have trigger spots, whatever may be the instability, these symptoms are common. But why we talk about these symptoms in flexion instability is because people don't recognize it. If you have, a globally loose knee or extension instability and hyperextension, everybody know the case of instability. But we tend to miss flexion instability, and that's why these symptoms are talked about. But symptoms are universal. So if you leave a knee loose in flexion to get high flexion, for example, the patient will may get high flexion, but they will be symptomatic of their instability. So that concept of leaving it loose.
The question is whether you would change your philosophy if you are doing a CR knee vis-a-vis PS knee, where you say that it should be equal in flexion extension exactly, and in CR knee, would you make it
I have to pass because I never do CR knees, so I have to pass.
Okay.
See, as I understand it, Vikas, if you are doing a CR knee, your gaps are really tight. As Manoj also mentioned that your flexion gap is tight. If you are doing a PS knee, moment you release your PCL, your flexion gap will open up slightly, 1 or 2 millimeter. So if you are doing a PS knee and you have a millimeter loose flexion gap, as Anup was mentioning, that may be acceptable, provided it is not unstable and anterior-posteriorly you are not unstable, as I showed in my case. So CR versus PS, this is a little different. That CR, the gaps are tight. So you cannot lose it, you cannot leave it loose.
Because can I make a point? We need to understand that the patient is anesthetized and paralyzed. When we are saying loose, once the capsule closes and the patient gets capsular and muscular tone back, it's just right balanced. But if you leave it tight, once the capsule closes and patient gets muscular and capsular contracture, it really becomes you may really end up with a 90 or 100.
Painful.
So somewhere we need to understand that the patient is anesthetized.
Anup, if I can say here, you are right that when the patient is anesthetized and he's out of the anesthesia, there will be an extension gap. But the flexion gap is primarily not affected. And I think the major mistake in flexion gap that people cause is when they are not examining it with the thigh interaction.
Can I ask a question to Vijay?
Yes, Anup.
Vijay, correct me if I am wrong, but mid-flexion instability, what you were talking about, is a term usually used for primary situations, more distal femur cut, slight medial opening due to removal of osteophyte. But the case you showed and the discussion you did was mostly on the revision situation. So help me clear my mind.
Mine was a primary case which I revised to I didn't show any revision instability in the revision case, not at all. There's a primary case which had the symptoms of flexion instability, but X-ray wise was not flexion instability, and examination was not flexion instability, so something else was going on, and that was mid-flexion instability.
So it was instability at around 10-20 degrees of flexion. That's what you're saying, right?
That's correct, yes.
Correct, yeah, all right.
Yeah, but it's very difficult when you do a revision to make the diagnosis of flexion instability.
You'll distalize the femur.
Yeah, I know. But when you have so much instability, it's difficult to know if there was a flexion contraction first, what they did. It's very difficult.
So, yeah.
Yes.
Could I ask a question to Manoj? Manoj is there?
Yes.
Manoj.
Go ahead, Ashik.
Yeah, here.
Manoj, you said you're doing 99% of your knees which are CR knees. What is in your hand or in your experience the incidence of late rupture of PCL and knee becoming unstable, which will require revision of some sort?
Yeah, I have gone across with multiple systems onto the CR. So it lot depends on those. And then ultimately, after doing say 20,000-30,000 of those knees, you tend to learn how to skeeve off the tibial attachment of PCL in the beginning. Majority of these late ruptures of PCL happen in two situations. A, while using a saw blade on a size 2 tibia, you intend to take off a bit of a slice of, say, 50-60% of the PCL at the tibial attachment, which subsequently on higher bending done by the rehab guy gives you a late rupture. If you are sort of secure on that part, it saves you in. B is the fact, many times I've seen surgeons, rather than sort of reapproaching their tibial slope, they try to release from the femoral side. Once you take off 50-60% of the femoral attachment of PCL and you give a high bending across or a rehab, that's another stage where you have a late rupture. So in those cases, many times you have to titrate with a bit of a tibial slope as a parameter, then taking off the femoral or the tibial attachment for a very small size 2, 2.5, 3 size tibias. If you sweetly tangle these situations, the chances of late rupture of PCL are way lesser.
Yeah.
Couple of those people would use a disc insert. I don't use it, but couple of people use a disc insert to circumvent these changes. For all CR knees, which I don't think is a very good answer, you can have disc insert as a backup on the table if you're a CR user, but to use a deep disc insert in everybody is not a very sensible proposition.
Right, thanks.
Well, yeah,
Hey, may I make a
why
point
you
here?
say that,
Because
Manoj?
about
Yes,
mid-flexion, Vijay.
Yes, Bharat.
There's a sweeping statement there. No, let's finish this one. I use deep dish for nearly 99% of my cases. I take the PCL off and use deep dish in all the patients.
Vijay,
Yeah, a lot of people do that. Yeah.
Vijay, may I make a point about mid-flexion instability, gentlemen? One of the reasons why it has remained a bit woolly and why it has not been clearly delineated, and I submit this for your consumption, the collateral stability is designed in the native knee, in the anatomical knee, by virtue of the fact that the fibers of both your collateral ligaments are absolutely done to perfection to suit the contours of the lower end of that individual femur. And we, all of us know that the lower end of the individual femurs of different individuals are different in their J curves. The instant center of rotations are custom made, and the collateral ligaments are also custom made for that given sort of pattern of the instant center of rotation. When you replace the lower end of the femur, the contours of the lower end of the femur with a factory made standardized J curve, whether it be X implant or Y implant, many times you end up getting a collateral complex which is not obviously designed for this particular geometry of the lower end of the replaced femur. And that is why no matter what the surgeon does, there is a chance that there will be a small amount of instability. And when this factor is amplified in some small proportion of cases where the muscle tone is not able to compensate, like Anup was just mentioning a minute back about in some other context, that is when you find that the patient will develop mid-flexion instability, which is most manifest when going down the stairs, for example, where the femur tries to slide off in towards the front of the tibia or off the tibia. So mid-flexion instability, despite I mean, Vijay has very rightly pointed out it's a woolly area, and I don't think Vijay is still completely out of that woolly area himself. But then so are all of us here. In the same boat.
Bharat, that individual anatomy matters, but the more amplification is, suppose if you elevate the joint line by 5 millimeters, 100%. By 2-3 millimeters, by undersect the tibia and then you raise the joint line, and that's when it compounds your natural thing that we're talking about. That's what in the surgeon's hands. That's what in the surgeon's hands, and that's what we must be better at. Yeah.
I agree, Vijay. That's the most common reason for that. Yeah.
A lot of wisdom, which Dr. Bharat has just said. There are lots of things which we actually don't know. We are going into a lot of technical issues on various navigational fronts, etc. But of course, the biology is very individual, and we are evolving. And we hope that over a period of time, we are able to overcome these nuances of anatomy, which is so much variable in various patients and various people. So it has to be a more customized solution in future, which would come. And I think we have other friends who did present cases. If they have anything to add, Rakesh, are you still here? Would you just quickly say that if you had an option of a constraint on that table, would you have still reconstructed the MCL?
No, I think, Vikas, I think the literature is now very clear that if you have something acutely on table, the reconstruction of ACL is a much better way to go forward rather than having a shift to a highly constrained implant. There is no doubt about that. But you have a very mild instability, then maybe you can just go to something like a TC3 or one of those higher constrained implants, but not a hinge or something.
Your case, the one which you did.
No, in my case, what I think.
If you had a
no. I had on the table, by the way. So I always have a higher constraint with me, always on the table. But we chose to actually reconstruct because we could actually reattach the original MCL also, because mine was an avulsion from the bony tibia. But I was finding that the bone was so porotic that my reconstruction might be doubtful. That's why I did the hamstring reconstruction also, and with the same swivel lock, we fixed the actual original MCL also.
Yeah. So nowadays there are also studies which are saying that these grafts, they do stretch out over a period of time, and so people have started adding internal braces to protect the graft to some extent. That's a new addition in the way forward. And
my worry with Vikas with the internal bracing is that it's a foreign material which is going to stay. And in a TKR where you are really worried
have
about
a lot of foreign
so
material.
that would be my worry for a normal ligament reconstructions, like for a trauma cases. I don't. That's a good idea probably, but for implant related cases, I don't think it will be a very good idea.
Yeah, it's basically a fiber wire, nothing.
Yeah.
Can I add something to this? Now, when you have an acute MCL injury, whether you do semitendinosis or acute repair, you augment the semitendinosis, the most important thing is post-op bracing with a hinged brace.
Yeah.
That is the key point. And that you have to do hinged brace for 6 weeks. That is the key that's going to determine your success. More than these technical issues. Like an acute MCL injury that you see, traumatic injury without a TKR, bracing is really the way to go.
So Vijay, I'll come back to the case you presented. I want to ask a question. I've been keeping quiet for some time. This mid-flexion instability is now occasionally seen when we do robotic ones also. You can actually see the gap at something like 45, 50, and I actually have a case. So if you see it actually on table, Anup, you can also probably pitch in there. What do you do to correct that on table if you see it when you're doing robotics?
Yes,
Anup.
Yeah.
Said something. Yeah.
So it's very interesting when you do robotics, you can actually see the gap. And if you have medial cartilage loss and your medial gap is opening up, you can actually internally rotate your femur. Internally rotate means from the PCA axis, not from the interepicondylar axis. So you can rotate 0 from the PCA axis, which is actually 3 degrees parallel to the interepicondylar axis, provided you have medial cartilage loss. So you can actually do a lot of those things to prevent opening of the medial gap and prevent subtle instability patterns. And it's interesting, Rakesh, you would bail me out on this, that mostly using a 9 poly. So mostly use the minimum poly because you can actually see the gaps virtually.
So in my case, the one I had, I tried all this. The best thing what I found was you slightly flex the femur, and you actually that was corrected.
So Professor Bryard, your take on internal rotation of femur, which is being discussed here.
Well, for me, it depends in where you want to discuss it. But if you have a femur varum, well, you know, when you do a total knee, you try to build the alignment. And if you have a femur varum, and if you want to have the joint line perpendicular and all this, well, you will have internal rotation. So for these cases, I tend to need, if there is no malrotation due to a non-union, malunion, I don't want to have internal rotation. I do a sliding osteotomy. So I think we must build the knee. We have the transepicondylar line. We want it to be perpendicular to the joint line, and then it's rotating underneath. And underneath, you can do you can release, you can do some things, and it's possible, but not on the femur. You do a sliding osteotomy, and then you have like a transapical line perpendicular to the mechanical axis.
Because can I grill Dr. Brad slightly? Dr. Brad, 2006, I had sent you one X-ray of a severe varus, which is the first time I came across of at the joint and also at the tibial metafacial area, very severe varus. And I had said to a lot of people about how to go doing about it. You were the only one who replied back to me, actually. You showed me a case where you had done a metafacial osteotomy and put a very short stem on that and put a staple, if I remember rightly. Yeah. The two staples were put in. And that gave me an idea actually to go ahead and actually, make this operation of one-stage correction of intra-articular and extra varus. So the same case which was presented now, where we showed the medial condyle osteotomy, because the lateral laxity is actually many times in this case pseudo-laxity, because the medial side condyle has really gone up because of the defect on the tibial plateau, and you get a lateral laxity which is very pseudo, even on examination during robotics. It's not a true laxity which is actually reflected on the robotics. So in these cases, correcting varus at the tibia, where was the original deformity, is actually in the tibia, and then cutting very less of tibia and correcting that laxity, because you are correcting that by cutting very less of tibia. That is what you had suggested to me long time back. You seem to have changed your mind now, is it?
I think yes. It's pretty long.
Well, I have one case where you have a varus knee from the femur and from the tibia. It's maybe 25 degrees. I did a sliding osteotomy on the femur, and I released until inflection. The transapical line is perpendicular, parallel to the tibial cut.
I remember that case, Dr. Brad. You told me you had lots of wine before you devised this operation for that case.
So thank you. I think this would be an endless. We will keep on talking. There are too many enthusiasts today, but I think we have been able to match the time, and we have just been able to finish our lectures. And my compliments to all the presenters. They have been exceptionally sensitive to timing, and starting off with my opening batsman, the favorite Anup, and he sort of did it well within time, and everybody followed. And thankfully, it made my job very easy. And it has been a very good discussion. I think we are falling short of time. So now I would ask our president, who has encouraged us a lot to make these webinars successful, to say a few words of thanks, and thanks to all the participants for tolerating me as your moderator. Thank you.
Thanks so much, Vikas. I think it's a wonderfully managed timeline and a difficult subject. Thanks, Dr. Briard, for being with us. I think for the unstable knees, you have the best understanding. What we know and what we have been discussing between you and me for last more than 20 years, I think that instability of the knee has been the core issue for you right from the beginning when I started doing the LCS knees with you. Thank you so much for being with us today for more than 2 hours. Thank you so much for all the speakers who gave a wonderful talk, wonderful case presentations. I think that we are having a very, very good material with us with our Indian arthroplasty surgeons. I'll just announce lastly for the next webinar. Can I just share the screen, please?
Yes, please.
So members, we can see our webinars on our IndianArthroplastyAssociation.com when you go to the association website, and you can become the member just by going to the website and clicking on the member icon. The next webinar that we are having, the Dr. Abhay Elhens is moderating that webinar and organizing that webinar on a very interesting subject of femoral stems in primary and revision total hip arthroplasty, biology, metallurgy, and philosophy. We will be having probably 2 or 3 speakers from abroad, and hopefully we'll have a very good discussion as we had in all the webinars that we have been having. We'll be circulating the program probably by next 4 or 5 days, the final program. And friends, you can become the member on our website. And let me tell that our present membership in the last webinar was 705, and just now Dr. Rajkumar, our secretary of our Indian Arthroplasty Association, has informed me that in last 1 month we have increased the membership by another 28 members. So I think we are having a very good support from our orthopedic fraternity, these young surgeons who are wanting to become the arthroplasty surgeons. We are happy, very, very happy to have our membership increasing month by month. Thank you so much, everyone. We'll close the session now with a big thanks to all of you. Thank you so much.
Thank you.
Thank you.